Hi, welcome to the 2021 Academy of Oral Surgery's Fall Symposium. I'm Dr. Kayvon Javid, the host of this program. I would like to thank you for joining us and hope you will enjoy our program. Hi, welcome to the 2021 Academy of Oral Surgery's Fall Symposium. I'm Dr. Kayvon Javid, the host of this program. Today, I would like to introduce our guest, Dr. Hakimian. Dr. Arash Hakimian is a cosmetic and implant dentist in Los Angeles, and he graduated the top of his class at UCLA. He completed his dental degree at USC with honors. Dr. Hakimian teaches advanced surgical techniques, dental implants, bone grafting, as well as business management and marketing to dentists around the world. He's licensed by the state of California as a continuing education provider. He was chosen in 2018 as one of the top 40 dentists under 40, and again in 2019 as the best cosmetic dentist in Los Angeles by LA Magazine. He's currently serving as the CEO of Denture, a technology company providing mobile dentistry and tele-dentistry services. Dr. Hakimian takes great pride in providing free dental work around the world and has helped several organizations locally and in developing countries in establishing or improving access to free dental services to underserved populations. Dr. Hakimian was the co-founder of the Global Dental Implant Academy and serves on the board of directors at the International Extraction Academy. Welcome, Dr. Hakimian. It's a pleasure to have you today.
Hi, everyone. This is Dr. Arash Hakimian. I'm so happy and honored to be invited back to speak with AOS and share with you and the entire world and our amazing clinicians from across the globe some innovations in dentistry, including telemedicine, artificial intelligence, and some of the emerging technologies that are going to be shaping really the future of dentistry. And, you know, we've all seen it all, especially in the last couple of years, that there have been tons of changes in our industry, and we can expect to see an accelerated number of changes throughout the next couple of years, especially with these technologies that are being implemented. And really, change is the only constant in life. It really is. And things have really changed over the last couple of years, but they've changed over the last 15, 20 years. And our ability to adapt to these changes have really determined and will continue to determine our success, not only in life, but in our practices. Just a little background on myself. I am a practicing clinician. My mom, dad, brother, sister, everyone's involved in dentistry. And I've had a really amazing and fruitful career touching on different aspects of dentistry. So I've been involved in mobile dentistry. I've been involved in telemedicine. I've actually been a practicing surgeon for many years. Majority of my practice and my focus was on implantology. Even though as a GP, I participated in cosmetic dentistry and other aspects of dentistry. Really, my love, passion was in surgery, and had the pleasure of traveling and teaching and lecturing on the subject. And one of the things I also really loved to do was volunteer work. And that's how I really got into some of these technologies, because we had to reach patients in some really remote areas. And we utilized mobile dentistry and tele-dentistry initially, and bringing this technology into expanding access to care is how I was initially introduced to these technologies. But now that we've gotten involved in it, we now see more and more of artificial intelligence, machine learning, and some really, really amazing things that are going on in dentistry. And really, it's my unique pleasure to be able, as a dentist, to be able to share this with you all. Now, I want to make sure I give you a disclaimer. I am the CEO of one of the leading tele-dentistry companies. We've been honored and blessed to have won the best of class technology the last couple of years at the American Dental Association's annual meetings, and really fortunate enough to have had the opportunity to be recognized and be able to be on both sides as not only an attendee for many years, but now as a exhibitor and bringing these technologies to dentistry. And so a lot of the slides and cutting edge examples that we'll be showing is based on things that we've actually developed at Dentulu and some of our amazing partners who now work with Dentulu to bring this technology out to market. Now, Dentulu was and is a mobile and tele-dentistry platform where it now allows dental professionals to expand their reach outside of the brick and mortar dental office into on-site care, not only utilizing telemedicine to be able to talk to patients virtually, but also being able to compress the dental office into these mobile units that go to people's homes, to senior centers, and to pretty much any location that patients are located. So now we are really looking to help existing dental professionals and those who are now moving into retirement or just starting out their career, be able to expand their reach and opportunities. But as we've gotten involved in teledentistry and mobile dentistry, we've seen that there are other technologies that we can incorporate into our traditional offices to really make our lives easier and really better serve our patients. So some of the things we want to talk about today include obviously teledentistry, some of the use cases for mobile dentistry, artificial intelligence and how that's shaping, and shaping not only our in-office care of patients, but also how it's getting incorporated into remote patient monitoring, even billing and management. And then how we can utilize these to increase productivity and generate more patients to our offices. And then the future trends and opportunities that are present for providers and the dental profession. So one of the amazing things, that we have to really take into consideration when we step back is that in the past and throughout history, it's usually been new product innovations that have really driven commercial success. So we get new sensors, and that new product and technology really started shaping how we take x-rays, or CBCT scans really shaped how we diagnose our patients. And usually these products and innovations are the main driving forces of the medical and dental industries. But now we've seen over the last couple of years that external macro trends like the pandemic have really exerted this tremendous amount of influence and are also shaping, in such a massive way, the way that we practice dentistry. And so not only do we continue to see new products and innovations shaping what's going on in our profession, but now we see these macro trends and changes in, economics and in legislation that are now having a significant influence. And it's a really unique time and period to be practicing medicine and dentistry, because we have this dynamic forces that are really affecting how we practice dentistry. And some of these macro trends, as I mentioned, include rising pressures to change the economics, to reduce some of these healthcare expenditures, shifting some of these payment models, and distributing the risk sharing between not only the providers, but also the industry, providers that give us a lot of these technologies. And so value-based arrangements and more distributed risk sharing structures, including heightened demand to increase access to care and really bring some of these treatments that we do and some of the care that we provide to where the patients are located. And this is really stemmed from consumer demand. Consumers now can get, their taxi rides, they can get their movies, they can get their shopping all on handheld devices and from the comfort of their own homes. And so there is also this massive drive from the consumer side to be able to provide more convenience. And so the consumer demand and the industry demand are both really some macro trends that are affecting dentistry and how we move forward. So the COVID pandemic really just accelerated what was going to happen anyway. We already had lots of consumer demand on convenience and on-site care, but with closures that were occurring across the nation and across the world, we really saw tons of offices closing. We saw our chair times reduced, and now we're forced to figure out how do we really pivot and shape a new type of normal for our dental offices. And so the COVID pandemic really put telemedicine and mobile dentistry on the map. But even before that, we've seen, believe it or not, massive shortages of healthcare professionals in what we call dental deserts. So even though in some of the major metropolitan areas, major cities, lots of dentists, lots of competition, we can see that still there are these remote areas across the nation and across the world where patients, believe it or not, still don't have access to care. And there is a limited amount of dental professionals and specialists. And so we are now figuring out how to utilize this technology to bring care to these patients on site. In fact, it was incredible to see patients pulling out their own teeth, not only during the closures and shutdowns, but patients continue to try to self-medicate and try to figure out solutions, sometimes out of fear, sometimes out of cost, and sometimes just out of sheer necessity when dental offices are closed after hours and they just can't get the access they need to care. Believe it or not, 3 in 4 patients still continue to experience obstacles to getting oral health care. So here we are as dentists wondering, where are our patients and how do we get more patients through the door? But really on the other end, there's still patients who are really having a hard time finding care. And can we use technology to kind of address these issues? Millions, 74 million Americans still have no access to healthcare. And about 40% of the US population still, battle with annual visits. More than 60% of the annual population still don't have annual visits to a GP to get their checkups. So let's evaluate these real quickly. Some of the factors include traffic, the logistics of sitting in traffic and getting to a dental office. Imagine getting to a dental office and then having to now, with these reduced quantity of people that we allow in our waiting rooms, how long the office wait is, how many people can we actually bring at a time? Do we have to miss work? Believe it or not, 164 or more million hours of work are lost across the nation, with dental care. And this translates into billions of dollars of lost income opportunities for these corporations. So now they're getting smart and figuring out, hey, can we kind of figure out how to reduce our losses and bring some of this work on site? And as we will show you, a lot of corporations are now bringing dental care directly on site. And how can we as dentists participate in these? And geriatric and disabled patients, being able to just travel to the dental office is a challenge for many people, and they have to schedule care in advance. They have to schedule their transportation in advance. Coming back for post-op checks and just basic cleanings and exams is a huge challenge for millions of patients across the nation. And so a lot of these patients end up in emergency rooms. And what ends up happening is they're prescribed opioids, and we're really in a negative way contributing indirectly to the opioid epidemic. And also costing billions of dollars to our emergency rooms, having to take on dental patients that can otherwise be treated in dental office. So can we do better? As we mentioned, over 181 million Americans won't even visit a dentist according to the ADA. Over 50% of Americans over 30 have gum disease. 25% of Americans 65 and older have lost all their teeth. 2.2 or more million emergency room visits for dental related issues. And let's talk about the children. 55 million school hours are lost annually for kids who have to leave school to go to the dental office for dental related issues, majority of which are actual problems, is pain, is infection. And this is really translating into not only lost school hours for the kids, but also the parents have to leave school, have to leave work and take these kids to the dentist and pretty much spend 2 to 3 hours addressing issues that could otherwise be addressed with preventative care and on-site care and maybe even telemedicine. So the medical industry has really, advanced significantly faster than the dental industry has. And we can see from, home monitoring to cognitive health to diabetes care, senior care, woman and family health, and even sleep medicine has really expanded dramatically over the last 10 years. And they have really incorporated not only the equipment and hardware, but also the telemedicine and as the billing as well. And dentistry is really lagging to catch up. But these changes have all occurred because there's such a massive acceleration of growth in technology. We can see from social media and our day-to-day interactions on how do we communicate with our friends and family, really transform from Facebook to Instagram to TikTok, to how we receive medical consults through major companies like Teladoc, to how we receive, entertainment on-site, whether it's on our mobile phones or on our, on our television sets. We no longer have to go rent that, DVDs. More and more people are avoiding going to movie theaters and just getting that entertainment on site. And the taxi and car ownership industry is really transformed with companies like Uber and Lyft. And again, like shopping is something that we traditionally, have done in local mom and pop shops. And even major retailers, but now we've seen a massive trend and movement towards, online shopping and on-demand care, on-demand services. So the acceleration is occurring so fast that we are now having a massively hard time just keeping up with it. And there's this adoptions and cycle that we go through. And initially, everyone's so excited. Yeah, telemedicine's great. Tele-dentistry is wonderful. We all get excited about it. And really, I think where we are today is we've all realized, okay, there's benefits here, but we still can't do root canals. We still can't do surgeries. We still can't do a lot of procedures. So there's this downward slope of, okay, reality is hitting, we can only do certain things. But then we realize, okay, how do we expand on the things that we can do and what other applications there are? And really where we are today is in this early majority. We've passed the early adopters. There's plenty of dental offices and dentists who've gotten involved in teledentistry and telemedicine. But now we're seeing really the early majority. We have insurance companies. We have some of these massive institutions getting on board. And what we'll see now for the next 5 years, maybe even longer, is more and more people getting involved and realizing that, okay, there is some viable things that we can do through teledentistry and through mobile dentistry, through artificial intelligence. So this is where I feel like we are in this adoption cycle. But we have always been really slow as a dental industry to adopt change and adopt innovations. Some of these have really resulted from poor legislation. Some is we just don't have access to hear about these innovative, solutions as an industry. So policy making and also a lack of just good platforms through which we can be exposed to innovations have been really instrumental. So it's amazing to see some practices still using paper charts and traditional x-rays when we've had solutions for these now for decades. And we will see the same type of slow adoption with teledentistry and artificial intelligence. But I believe now, because the rate of technology is accelerating so rapidly, I think that this adoption rate will significantly be reduced, especially now that the consumer demand is on such a massive rise. And really, I'm proud and honored for dentists who have stepped outside of clinical dentistry to now get involved in some of these technologies. And these are some of our fellow dentists who've gotten involved and really taken a leadership role in not only promoting some of these technologies, educating dental professionals, but also spearheading some of the changes on the legislation and also on the insurance side as well. So let's talk about some of the healthcare trends that are occurring and some of the massive institutions like major retailers, pharmaceutical companies, and also online stores who are now getting involved in telemedicine. CVS Health, Rite Aid, Walgreens, Albertsons, they have now all to some degree started implementing teledentistry. And you know, we've seen companies like Smile Direct Club, who in the past have provided clear aligners to consumers utilizing components of Tele-Dentistry. But now we see major retailers really adopting some of these on-site scanning, on-site impressions, on-site visits and kiosks. And what we see now is a collaboration between some of these major retailers and Tele-Dentistry companies. And what's important is really that we as local dentists, as traditional brick and mortar offices, stay involved and participate in some of these new innovative models so that we can benefit from some of the amazing opportunities that companies like Smile Direct Club are benefiting from. We have dental insurance companies, pretty much all the major insurance companies have now created Tele-Dentistry codes, and the American Dental Association and the American Association of Dental Boards have all recognized the massive benefits of some of these new technologies. So when you look at the major DSOs, insurance companies, and the massive institutional and corporate adoption, we can really rest assured that this is an innovative future that we can't avoid and sweep under the rug. And we all, as practicing dentists, specialists, have to get involved and really stay up to date, because this technology is coming and this is shaping the future of our profession. So better to stay involved and proactive about how we incorporate these. So let's talk about the Uberization of dentistry. Uber really came by and completely transformed the car industry and provided a lot of these services back to the consumer. The consumer started getting a lot more power and control over the direction of the type of services that we're receiving in the taxi industry. We've seen that with food delivery as well. We've seen it with real estate. We've seen it with telemedicine. And now you can see on the right where dental companies like Align Technology, Smile Direct Club, Dentulu, Henry Schein, the Tele-Dentist, a lot of these companies are now popping up. And so there is a lot more corporate movement into on-site care and the Uberization of dentistry. In fact, Uber Health just appointed Ms. Donovan as the new general manager and head of its health business. And Ms. Donovan actually came from the dental industry. And we can see even Uber, who's Uberizing, so many different industries, is now getting involved in the healthcare and has even appointed a dental professional into their healthcare platform, who's leading this movement on their healthcare division. So what is Tele-Dentistry? So Tele-Dentistry is the use of communication technology that can be used for oral health assessments, consultations, for education. And the main two components that we're all familiar with are synchronous and asynchronous Tele-Dentistry. To make it very simple, synchronous Tele-Dentistry and telemedicine is being able to, in real time, speak to patients, whether it's through video or picking up a telephone and communicating with your patients, and using technology in real time to connect patients and providers. Whereas asynchronous Tele-Dentistry is collecting information, whether it's charts, diagnostic materials, models, and then having a provider or professional evaluate that that information, provide an assessment, review it, and then be able to get back to a peer or a patient at another time. So when you think of synchronous, think of live video consults and phone calls. When you think of asynchronous, think of photo consultations, chart reviews, and maybe second opinions. And then there are other modalities such as remote patient monitoring, where we're able to, monitor our patients over time, and mobile health, which is accessing, patients and having patients access their health information directly on their mobile phones. But generally, for the majority of the scenarios, we're either going to have a patient app or a patient account online. Doctors are going to have their own app and online access. And patients will sign up, they'll review and figure out which doctor they want to see, they'll book an appointment, they'll usually get a confirmation for that appointment, and then we'll go through some kind of an interaction with the dental professional. And then a payment will occur. And in most cases, the patients will have the opportunity now, just like they leave online reviews on Yelp or Google or Facebook, they will be able to rate and review that doctor. And doctors will follow a similar flow. They'll usually register and sign up a professional account. They'll create an availability, and then they'll go ahead and approve and screen appointments. They'll interact with their patients, and then they'll get paid. And generally will either provide some kind of a diagnosis or a prescription or some type of feedback to the patient. And so that flow is the general and accepted flow for teledentistry and telemedicine. Now, as I mentioned, the Uberization of dentistry really follows and similar parallels that we've seen in other industries, which is very disruptive. It includes some type of a mobile technology. Patients can usually access the type of service they want on demand. And there's this direct connection between the patient and the provider. The same way there's this direct connection between the consumer and the Uber driver. Now we have consumers being able to on demand, using their phone, find and review a doctor, and then communicate directly with the provider of choice. And the consumers are now, the patients are now having a little bit more freedom and control over how they schedule, and then being able to give their feedback so that other providers in the future, other users in the future, can pick the right type of provider that's the right fit for them. So we see these same characteristics that occurred in the taxi industry and other industries occurring now in dentistry. So some of the things that this is going to solve is lack of access to dental care, being able to avoid having some of those patients go up in emergency rooms, being able to decrease some of the expenses that we as dentists have to face, seeing some of the patients in office for post-op checks, some of the personal protective equipment that we have to use can now be utilized on patients that we're actually doing procedures for, and be able to now shift some of these procedures to a virtual care so that we don't have to spend so much time checking in patients for 5-minute PO checks that we do after surgery. And it's also going to really affect the patient acquisition and retention modalities. How do we acquire patients? Can we screen some of these patients virtually first, and maintain some of those patients in our practice and reduce the amount of patients leaving on the other end? We're so focused on generating new patients. Many of us need to also realize that these technologies can actually help us maintain and keep some of the patients in our practice and reduce the amount of patients that are lost. And just increasing the efficiency in our offices by utilizing artificial intelligence and some of these technologies to be able to help us manage our day-to-day operations better. And last but not least, obviously, reduce the amount of exposure to COVID and other infectious diseases, and being able to provide some of the care and continuity of care without exposing ourselves and other patients to potentially infected patients. So let's skip through this and go through some of the applications of teledentistry, and beyond beyond the video calls. We are now using HIPAA compliant teledentistry to be able to streamline referrals, not only to other specialists, to other GPs, but also between medical and dental doctors. Being able to better communicate with our patients directly on their mobile phone through chat, through constant ability to share files and photos and x-rays, and have better communication with our patients, not only on the dental side, but also on the medical side. And being able to now empower some of our hygienists and mid-level practitioners to go out on behalf of our office and provide some of the care that we provide in our offices under our general supervision, and then funnel those patients back to our offices. So hygienists now, there's I think over 50 bills in Congress allowing hygienists to go out and provide some on-site care, and general dentists can now participate in that and utilize some of these mid-level practitioners who are more readily available to go out and treat some of our patients, and then bring back some of the more productive and necessary cases on site. And then being able to coordinate care with disabled and geriatric patients, and be able to monitor some of our patients outside the dental office when they leave. So one of the things that I think is really important is to be able to utilize actual mobile technology, is to be able to utilize telephones and cell phones and iPads, which everybody has now, to be able to do that real-time conferencing, but then also be able to utilize these devices that everyone is holding to alert patients and give them reminders and be able to schedule their appointments. So the combination of synchronous and asynchronous dentistry really provides a good comprehensive modality for us to be able to communicate and really participate in these new technologies. And none of these are new. We've seen this technology now present in over 100 years. Telemedicine has been involved in the medical side for over 100 years. EKGs were sent through telephones, through Morse codes. And so while this may seem like relatively new technology to us, really this has been around for decades. And some of this stuff has been around longer than a century. And medical doctors and dentists have now studied this in collaboration with larger institutions and have proven these to be not only effective and safe, but really, an integral way to expand access for care. And some of these benefits, as I mentioned, is increasing access, allowing more timely diagnosis of early care, from early cancer to early periodontal disease to early cavities, and then allowing providers also to gain some benefits in maintaining some distance from potentially infected patients who have other health conditions, reducing some of the wait times, allowing us to better effectively triage our patients, and then improving the quality of care by maintaining that continuity of care with some of our patients after they leave our office, and being able to see how our implants and surgeries and soft tissue grafts are doing even when the patient leaves. And then minimizing the amount of societal burdens that we have and the cost that we're putting on our caregivers, on the healthcare industry and our school systems as well. So as I mentioned, teledentistry is on the rise. It's here to stay. It's not going away. And the ADA is spearheading some of these innovations and policies that are occurring. Companies like DentaQuest and insurance companies have surveyed tons of patients who actually experienced teledentistry, and 86% of these patients said that they would use it again. 93% were able to easily understand what the dentist was saying, and the dentist was easily able to discern and determine what the patient's actual problems were. So there wasn't a massive reduction in communication and ability to understand one another, and that 86% of patients would actually recommend this to other people. And we can see now, again, bills and acts that are implementing some of these policies and really, putting some of these innovations within the legislative code, and then being able to have insurance codes follow so we can actually get paid for some of these services. So if you're not familiar with these codes, D9995 and D9996 are codes that you can actually utilize to bill for teledentistry, and the same price that you would receive, the same payments that you would receive in office, you can expect to receive utilizing these teledentistry codes with the majority of PPO insurances. And even the Medicaid system and the Medicare system are now starting to pay for teledentistry consults. So one example of the applications of emergency teledentistry care is, as I mentioned, the 2.2 million patients that end up in emergency rooms after hours when we're closed. 70% of those dental emergencies occur when all the dental offices are closed. So about every 14 seconds, a patient ends up in an emergency room looking for dental care. And so now we have this opportunity to, take some of these patients, avert them from the emergency rooms, triage them, and if necessary, prescribe medications, and then see those emergency patients in our dental offices. And the big fallacy here is that these are all patients that can't pay for treatment, they can't afford it, they're Medicaid patients. But reality is that while there is a good portion of the population that is on Medicaid and that cannot afford dental care, there is also a large portion of these patients that can afford care and they just have nowhere else to go. And this is a great opportunity for local brick and mortar offices to capture some of these patients and bring them into their offices. So over 5 billion people around the world have mobile devices. And so we can now access these patients directly on their mobile phones, no matter where they are or when they're having these issues, and they can access care directly on their handheld devices. And so even some of the more underserved populations like the homeless communities, even they have cell phones. And we can now expand this access to care to some of the most needy and underserved communities as well. So here's an example of a patient experience. The patient goes on, creates a profile. They can fill out their health history, insurance. They can even add family members. And then they can begin browsing and choosing dentists that are available. So they can go into different categories. These are not necessarily specialties, but they can look for the type of dentist they're looking for, from implantologist to prosthodontist to holistic dentist to cosmetic dentist. And they can actually browse the different doctors that have created profiles and who are available. They can read bios on those doctors. They can see the doctor's availability. They can see the languages that the doctor speaks. And then they can sign consent, fill out their health history, and then pay for their call, and then immediately be connected to a dentist within 5 or 10 minutes. And that dentist will be notified that there's a patient waiting on the other end, will accept the call, and then they will go into a consult. So, while we can't do a lot of procedures like root canals and extractions, we can definitely see how our implants are doing, if there's trauma to the patient, if there's an emulsed tooth, if there's an abscess, if that implant actually fell out, or if it's just a healing cap that became loose. And we can actually see these things directly on the mobile phone, and then be able to determine what is a true emergency and what is not, and then bring that patient in if necessary. And if needed, we have the choice and the right and obligation to provide care in the form of prescription. So if we don't feel comfortable, if we don't feel like we need to, we don't have to. But if we see that there's something that we can do to alleviate that patient's pain, we can certainly do that through electronic prescriptions. And now states like California actually have required dentists to provide electronic prescriptions. So just being able to write scripts on the traditional pen and pad is no longer acceptable. And now we are obligated to all sign up for some form of electronic prescriptions. And this is another technology that has been incorporated into telemedicine. So not only can we triage our patients, but we're actually able to establish them as patients of records and then be able to prescribe medications for them. And working with hospitals and getting some of those referrals from the hospitals is something that Tele-Dentistry is really great at. From providing kiosks directly in the waiting room areas to providing hospitals with actual intraoral cameras, digital sensors, and a Nomad, we can now not only avert patients from going to the emergency room utilizing these technologies, but we can actually see some of the patients directly in the hospital. So there are tele-dentistry carts with high speeds, low speeds, air water syringe, and pretty much allowing mobile clinicians to go to senior centers and hospitals and actually provide care. So these hospitals are now adopting these carts, initially starting with a tele-dentistry or telemedicine visit with a dentist who can then determine what is needed and be able to send a hygienist or send an associate, or they can go themselves and have the equipment and hardware necessary to actually provide care directly on site. And we see the same thing in pharmacies. There's telehealth kiosks popping up in major retailers. So patients used to be able to just take blood pressure, but now they can actually check their heart, they can check their vision, they can check, any kind of issues they're having with their ears. And a natural transition to that is going to be being able to take intraoral scans and being able to provide intraoral pictures and videos directly from the pharmacy and have a dentist review that information and then be able to provide the patient with some consultations and possibly a prescription. And believe it or not, the scans can actually be taken now on site. So intraoral scanners are going to be readily available in major retailers so that patients can go take scans, and those scans can be sent to doctors for review. And whether you agree or disagree with providing some of these restorations, these are things that are now in many states legal, and it's important for us as dentists to be able to make sure that we provide this care at a high standard of care and at the same standard of care that we would in our dental office. So clinical collaboration is one of those exciting things that I think we can all agree that can really be helpful. Having the GP being able to loop in the dental surgeon and orthodontist, endodontist, the medical doctor, and even a family member or a treatment coordinator directly on the same call. And we can all collaborate and share x-rays in the patient's chart and be able to facilitate the care that the patient needs, as long as it's HIPAA compliant, as long as we are doing so in a safe manner. This is really going to just enhance the communication and be able to get us to provide treatment faster and be able to get more case acceptance by utilizing some of this technology to be able to have multiple people collaborate together at the same time. And now that we have patients on these type of technologies, we can now allow patients to actually book some of their own appointments. So if you have a new patient, you can create a column in your schedule and say that, I'm accepting new patients on these days, and allow patients, just like they reserve a table at a restaurant, be able to now reserve a new appointment. And you can just show up at your office and see multiple new appointments booked directly on your schedule, directly integrated with your EMR system, and really bypass some of the previous hurdles and challenges in a patient, having to speak to a secretary, and, God forbid, they don't pick up, it rings too much, and the secretary is having a bad day. We can now allow the convenience of having patients go directly into our schedules and being able to really facilitate that ease of access to new patients utilizing some of these technologies. And while we're at it, why not have our patients be able to access some of their personal health information directly on their phones and directly from their own devices, so that when we do have a new patient and the patient wants to be able to share this information with a new provider, why not allow the patients to have that access directly on a patient portal? So now you'll see more and more EMR systems and more telehealth companies, including a patient portal, where patients can view statements, see their upcoming appointments, track and review their treatment plans, and be able to also just maintain some of their personal health information, such as x-rays, probing charts, and be able to share that with their other clinical team. And really, another exciting and amazing component of telemedicine is now being able to remotely monitor our patients. A lot of us place implants and do surgeries on patients, and we do everything right. We do everything the way we've done it for many other patients, but we see that some of these cases fail, and we have no idea what's going on because we're unable to monitor our patients' behavior, lifestyle habits, and diet outside of our offices. And by enabling some of these remote patient monitoring technologies, we can now see what the patients are actually doing outside of the office. And we can also pre-screen some of our patients by remotely monitoring their hygiene habits and their dietary habits, their bruxism habits, even before they become new patients. And one of the ways we've seen that is by giving these devices to patients. This is one example of a device that can be given to patients that they can attach to their mobile phones that will actually not only light up the mouth, it will illuminate the oral cavity, but it'll also act as a retractor where they can take pictures of the different areas and structures with their cellular phones, and then being able to share that with the doctor. And you can see some really cute, amazing images here. We can circle, we can measure, we can write notes, and we can share this with other clinicians as well, directly from the mobile phone. And even more exciting is now this amazing technology like the mouth cam that provides almost the same quality as we have in our $1,000 intraoral cameras directly to the patients, where they can purchase $40, $50 intraoral cameras, and they can keep these at their home. We can use this to educate the patient. So after my patients leave for surgeries, for implants, I give them one of these cameras and I tell them to take a picture of the healing every single day. I can see how my implant site is healing. I can see if the sutures have opened up. I can see if that soft tissue graft has taken. I can also monitor their hygiene. And so not only do I have this opportunity now to put one of these in my patient's hands and allow them to check for plaque and calculus, but also be able to monitor some of my cases from the placement all the way up to restoration and beyond, and really get more information in real time or in an early, asynchronous manner on how some of these patients are healing after they leave my office. And really, it's also great as a early detection tool for cancerous lesions, for attachment loss, for abfractions. And when you have one of these in the hands of your patient, it's a great patient retention tool as well. Since they have this and they're connected to your office, they're less likely to jump around and go to another office because, hey, they have this accessibility to you, virtually, and they're able to now communicate with you and send you pictures and videos of what's going on. And you can now open up your chairs to actually do more productive cases instead of having patients travel all the way back to your office just to do a 2 to 5 minute post-op check that you could otherwise do utilizing this technology. So here you see a patient is holding a cell phone with a camera. There actually now exists even beyond just a camera with hygiene attachment. So we can now see where the patient is cleaning, add proxy brushes and interdental floss to some of these cameras. So it's not only a monitoring tool, but it's also a hygiene tool as well. And patients can see in between those bridges, implants, fixed hybrid cases. And then taking some of those images and now incorporating artificial intelligence to be able to evaluate what is going on, even without the dentist involvement or direct involvement. Patients can now take pictures of their gums, of their teeth, and we are now able to monitor remotely how the gums are healing by utilizing, artificial intelligence and machine learning to create alerts for the patients and say, hey, this looks like a cavity. This looks like recession. This looks like an infection. You need to speak to a doctor. Ultimately, they need to see a doctor. Ultimately, they need to come in for in-person evaluation x-rays. But this can be a really great remote patient monitoring tool that will alert the patients and inform, the medical and dental staff that something is going on, and then be able to bring them into the office. So patients can now capture pictures of their smiles, pictures of their bite. And if they're looking for a dentist, they can now send these pictures, share it with the doctor, and then have the doctor be able to evaluate those pictures and then give them feedback and progress reports. And carrying patients through clear aligner cases is a great example of how we can utilize some of these pictures and videos that we capture on the mobile devices to monitor the ortho patients as they're progressing through their ortho treatment. And the same goes for implants and surgeries as well. This is a great device that came out from a company that actually incorporates a hardware, the patient's cell phone, and the patient, puts their cell phone inside this piece of hardware, and it actually retracts and allows the patient to move this phone from left to right, capture the patient's bite, and then utilizes tele-dentistry and artificial intelligence to actually evaluate the bite and the movement of the teeth as we progress through the case. And this is another innovative and amazing company that's come out with a bruxism tool that allows us to actually evaluate our patients' bruxism habits, in the evening. So it's the same traditional night guard that you would expect to give to a patient, except now you can see how often they're grinding their teeth and how hard they're grinding their teeth. So while everything looks, nice and dandy, you can see that some of these cases are failing because we have patients grinding and clenching, maybe even, unaware of the fact that they're doing so. But now we can see this not only in real time, but we can evaluate this and evaluate our therapies for addressing some of these issues through tele-dentistry and remote patient monitoring. So artificial intelligence, and how is it used directly in our offices now, and some of the technologies that you can expect to see? Well, we can definitely use artificial intelligence to evaluate some of our CT scans, some of our Panorexes and bite wings. It can help us, basically decrease variability across the different types of providers that we see. So while one dentist, or hygienist is probing at 2 to 3 millimeters, the other is probing a little bit harder at 4 to 5. And so now this decreases variability and can actually provide increased, information. It can find open margins. It can find periapical radiolucencies. It can find and classify different types of restorations automatically for us. So imagine just scanning the patient, and immediately the artificial intelligence will provide you a list of the restorations on the teeth. It'll tell you where there's potential defects, and it'll tell you attachment loss and bone loss in various areas. And obviously, the clinician has a responsibility to oversee and evaluate all these. And there's going to be, a learning curve for the artificial intelligence over the next 5 to 10 years, where it'll just get better and better and better and better as it continues to get more input and data. It'll get more and more familiar with these types of restorations, and then it'll really decrease our need to be able to spend so much time just classifying existing restorations. As I mentioned, we can also utilize artificial intelligence to detect color, bite, oral cancer and precancerous lesions, and also utilize this to detect the shape and symmetry of patients, and even utilize this for measurements such as cephalometric analysis. Now here we have an example of a ceph that was that was traced by artificial intelligence, and then the other with a traditional orthodontist. The traditional orthodontist had to spend about 10 minutes to do this. The AI was able to do this in 1 second. And really, when we evaluate these two, there's almost no difference between the two. And so we can see now how much we can free up our chair time, how much we can free up ourselves by leveraging some of this technology, so that we can do what Tele-Dentistry and AI can't, which is the actual surgeries and the actual procedures. Here's another example of sensors that have been put in mouth guards, so that when patients are playing sports and impact athletics, we can actually see how hard they were hit. We can see exactly where the trauma occurred, and be able to evaluate what type of impact they may have had on the brain, and how many repeated trauma events occurred. And so just like the bruxism habits, this technology is also going to athletics as well. And we're all familiar with artificial intelligence and remote patient monitoring with just day-to-day oral hygiene, being able to see where our patients are cleaning, where they're putting too much pressure as they're brushing their teeth, and be able to provide brushing scores and recommendations on where do they need to brush better, and then being able to actually monitor whether they follow your instructions by connecting some of these hardware to the actual software, and then giving access to the oral healthcare team to be able to monitor these patients and give active feedback to their patients, and at the same time hold them accountable. Now, another exciting part of all this is utilizing artificial intelligence to be able to actually tell what our patients are, how they're feeling in real time. So as we have these engaging conversations with our patients, we can now take little cues from their facial expressions to the speech patterns to actually be able to recognize, are they sad? Are they happy? Are they motivated? Are they scared? Are they fearful? Are we going in the right direction? Are we communicating properly? Are we doing it too aggressively? And we need to kind of re-strategize. You can actually now, in real time, tell your patients emotions based on their voice, based on their facial expressions. And we can now incorporate these into the technologies that we use to be able to enhance our patient communication and make sure that we're being more effective when communicating, whatever it is that we're communicating to our patients. And again, facial symmetry, proportions, all these measurements that we're traditionally doing by hand can now be, utilized, taking into consideration the pictures and videos and the artificial intelligence. We can now combine this information and be able to provide the doctors with immediate measurements, which will translate into providing, the proper video, the proper cosmetics, the proper smile lines, and then being able to reduce some of the user errors and increase patient satisfaction. I want to transition to the last part where we talk about how mobile dentistry, this new and innovative way, which is not so new. If you really look back, dentists and doctors were doing house calls decades ago. And my father used to provide on-site care, and he used to make house calls to patients. I'm sure a lot of the dentists who've been practicing for a while are familiar with sometimes us having to pack up and go to our patient's home, and being able to help some of the geriatric and disabled patients on site. But now we've seen that expand outside of just geriatric care. We see that not only are we going to senior living centers and hospices, but we're now going on site to factories. We're going on site to people's homes, to elementary schools, to apartment buildings and universities. And whether it's a dentist who's going out there and providing this care on site, or in some states and areas, a hygienist, or even a caretaker who's able to capture some of this information and loop in a dentist. Tele-dentistry enables dentists to stay relevant, involved, and be able to monitor what's going on in some of these on-site settings and make sure that preventative care is being addressed and implemented, but also make sure that when necessary, some of these more invasive procedures are being referred to local offices where they can be done in the traditional brick and mortar setting. So the Uberization of dentistry has already started. Patients are now able to download apps, basically put in the zip code where they want the service to take place. And the same way they order an Uber driver to go to their house, they can now order a dentist or dental professional to their business, to their house, to a senior center. And that request will then be sent to companies like this, who have outfitted vehicles with basically the full range of dentistry capabilities, from extractions to even surgeries to cosmetic care, to we have companies that are doing braces, traveling orthodontists, and the consumers can now actually reserve and have one of these licensed dentists go on site and provide some of this care in the comfort of their own home. And dentists are now able to purchase extensions of their traditional brick and mortar offices and have associates and hygienists go out on their behalf. And there are other clinicians who don't want to necessarily spend $50,000 to $100,000 on an outfitted vehicle, but can now utilize technology like this portable units that geriatric house call dentistry is implemented, which includes a high speed, a low speed, a compressor, a vacuum, all in this portable kit, which oftentimes costs between $3,000 to $5,000, and allows a dentist or dental professional to simply pack up a small bag and be able to go on site with a digital sensor and a Nomad, and maybe a laptop, and be able to screen patients and then pop up a chair and provide some of the care, from cleanings to simple impressions and post-op checks, to anything like extractions and fillings directly on site. And so many patients are demanding this, and this is a thing now. This is going to be in a way a new norm, and it's going to be an extension of traditional brick and mortar offices. And we can expect to see this continue to expand, because not only is the ADA lobbying Congress to expand this, but there are already so many bills across the nation that are now increasing the level of access that patients have to care, and allowing mid-level practitioners to do it more and more, just as long as it's under the supervision of a dentist, and as long as they have a referral network to which they can refer for things that they cannot do. And again, here you see senior centers and hospices. On the right, you see the traditional patient who's disabled, or geriatric patient who has to reserve one of these vans and units a week in advance with a 4-hour window, just to go get a checkup or cleaning. And on the left, you see a hygienist who's, popped up one of these mobile units and these portable units. And there's an assistant taking notes, taking probing depths. And then the hygienist is able to provide some of the preventative care directly on site, and then be able to refer that patient only to the office when necessary. And really, I think that we should expect to see more and more of these portable units directly in people's homes for someone who has 3 or 4 kids who may have dental insurance but just doesn't want to spend the time taking one child at a time, getting babysitters, hire hygienists and dentists to do whatever procedure they're able to and comfortable with directly in patients' homes by doing these house calls. And this is also really great for fearful patients who would avoid the dental office at any cost because their anxiety triples just going to the dental office. We can now see that a lot of these services can now be more readily acceptable by patients just by changing the environment. So whether it's this amazing, these outfitted vehicles that have, 4 to 5 units or the portable units, house call dentistry is here to stay. And more the DSOs and bigger corporations are now creating these mobile networks. And really, this is an opportunity for dentists to get involved, if nothing less, provide some of those mobile services to their geriatric patients and be able to maybe once a month go out and actually provide care to some of the patients in their community on site. And this is not limited to actual, dental procedures like surgeries and extractions. We can now send mobile scanners and mobile, imaging units directly to the patient's home. And instead of having to purchase one of these large units, we can just hire one to go directly to where the patient is located, take the CT scan, take the intraoral scan, and send that information back to the office. And this is, something that I think big corporations are realizing can be really, a huge cost saving and increase efficiency of their employees so that the employees don't have to leave work just to get a basic exam. And the hygienist and dentist can actually come on site as part of these corporate on-site wellness programs, take the x-rays, take the probing, take the intraoral pictures, do the basic evaluations and maybe even the prophies on site, and then refer those patients to the office for actual traditional dentistry. So I invite all of you to participate, get involved. You can go to dentulu.com or just Google mobile or Tele-Dentistry and get involved in some of these organizations and create yourself a profile or at least educate and really familiarize yourself with these new technologies because these are here to stay. And the more you get involved, the more you'll be part of that early adoption cycle and really be able to benefit from the millions of patients who are looking for this type of care and be able to maintain, some level of involvement in this emerging, vertical in dentistry. And the same way that they used to say that, GPs will never place implants, they'll never do, surgeries. And we can see now that it's almost, a standard with general dentists to know at least some component of, surgery. I think the same thing is going to be evident in technology and tele-dentistry. And so I highly recommend everyone gets involved. Visit dentulu.com or just learn about any kind of tele-dentistry or artificial intelligence or mobile dentistry company in your particular area. And anyone who has any questions or if I can be of any service, please feel free to reach out to me directly on my email. And I would be happy to share any of my insight or experiences in implementing these technologies. And again, thank you so much to AOS. Thank you for the production team and to all of you who have spent your weekend learning about these amazing technologies, and really look forward to having the opportunity to come back and share more innovative technologies and solutions with all of you. So thank you again. Have a wonderful weekend and looking forward to seeing you again soon. Bye-bye.
What's going on, everybody? I hope you are enjoying this virtual conference put on by the Academy of Oral Surgery. And what we wanted to make sure that we did between a lot of these great CE courses is highlight some of the great companies that are out there bringing to all of you great products and services. And I've had the luxury over the last couple of years to meet with a lot of these companies. And so very excited this weekend to be highlighting some of them. And so wanted to start with a company that I'm really excited about. I've seen them at the last couple of meetings I've been in. They're doing some great work. And so I'm very excited to have with me today Shawnee Kahuya. Sorry,
You're fine.
he'll edit that
Kahuya.
out. Kahuya, there you go. He'll edit that out. Yeah. So excited to have with me today Shawnee Kahuya from Zana. How you doing, Shawnee?
Awesome. I'm doing great. Thanks for having me on, John.
Yeah, my pleasure. All right, so we'd love to get started and just have you share with everybody out there, what Zana is, the work that you guys are doing, and any details that you want to share in regards to, how they can learn more about it.
Yeah. So, working as a clinical hygienist, I had a lot of these pain points that were happening in my day to day while I was recommending patients to brush with an electric toothbrush. And Sean, who is the founder of Zana, he had started to develop this model and started thinking about what are ways that an electric toothbrush could actually help dentists with the thing that matters most, and that's patient retention. So, kind of our two experiences in the pain points we were seeing in dentistry came together. And basically what we did is we took an amazing electric toothbrush. It's equivalent to a Sonicare Diamond Clean. And first of all, we customize it with the practice's information. So it's private labeled. And this is awesome because, 2 times a day, 7 days a week, every time a patient brushes, their practice information is front and center. So it really helps the patient to feel connected to the practice in between their appointments. And replacement heads, this is a big thing where patients know that these are really expensive. So they either don't buy them, forget to buy them, just come in and complain that they're expensive, and it affects their oral hygiene. So what we did is we actually give the practice replacement heads to give to their patients for free when they enroll in the program. So this incentivizes patients to come back in, helps with the oral hygiene, obviously helps with practice retention. And it's just really a win-win for the patients and the practice. And there's no other electric toothbrush program that does anything similar to what we're doing. So it's just super exciting. We're really partnering with all of the people in dentistry that are here to make a difference and just make dentistry great. And that's what Zana's mission is right now.
I love it. So, I'll share a personal story. So I don't know how long ago it was, but had a electric toothbrush and needed to go get new heads and just got busy, was traveling or whatever, you didn't do it. And so what I found myself doing, to your point, is just going and buying a regular toothbrush and completely putting that to the side. So I love that you guys have recognized that. And also I think the other thing that was really, catchy to me when I first learned about Zana is that branding aspect that you guys are working with the practices on. And again, I think about it all the time. I think about how new patients come into practices, how those practices grow. I think about somebody being in their house and showing a friend or a colleague or a relative, their toothbrush, with the dentist's name on there. So love that idea and all that great stuff. So share with everybody, like, what's it been like, a lot of the new practices that are building this into what they do on a daily basis. Share with everybody kind of what that feedback has been like from a lot of the customers you guys are working with.
Oh gosh, practices are loving it. I mean, we have the more and more we're out there, we're hearing a couple different things. One of them is we're not even selling electric toothbrushes in our office because we can't compete with Amazon. And we know that the patients can get them cheaper. So they're either not doing it. Some of them are actually buying replacement heads themselves and giving them away to patients because they realize, okay, why am I giving a goodie bag that has a manual toothbrush in it that we don't even want our patients to use? And I'm wasting money on that. And then they end up just, giving it away or throwing it away or whatever. So they're actually buying the replacement heads to replace in the goodie bag. And when they realize that there's a way to actually do that, that they don't even have to pay for the replacement heads, they're super excited about that. So we are, oh my gosh, expanding like crazy with our practices, and the feedback has been amazing.
I love that. And then how about patients, right? I'm sure some of the practices have shared with you what it's been like for the patients. Like you mentioned, they could get them less expensive if they went online or what have you. But, having it be given to them from the practice, like you said, creates that stickiness and strengthens that value add from the practice perspective. How's it been from a patient's side of the equation?
Yeah, for sure. I mean, if the patient ends up buying a brush from a practice, let's just say that it's a brush that they end up seen on Amazon or wherever, Target, that they could get for cheaper, they're starting to think like, what else is this practice overcharging me for? So it starts to erode that trust. So from a patient's perspective, when they realize like, oh, I'm getting half off a brush, because the practice actually gets to enroll their patients for half off. So the brush is valued at twice as much as what the practice is giving them, giving it to the patient for. So right away, they're getting an awesome deal. So they're excited about that. And then when they actually think about it, no one really thinks about like, what is the long-term cost of owning an electric toothbrush? It's kind of like a printer. Like you buy a printer, and then years from now, what are you actually paying? It's the ink. That's like super expensive. And that's the replacement heads. And so when the hygienist is really explaining to the patient, not only is this necessary for your oral hygiene, but guess what? You are only having to pay $100 one time. 5 years from now, you still just paid $100. Whereas if you bought the other brands, you'd be paying close to $500 in 5 years from now with the replacement head cost. So the patients they think it's a win-win. And even patients that they belong to a practice that doesn't have Zana, they're like, oh my gosh, how do I get this in my practice? Because it's just such an awesome deal.
So who in the practice, Shawnee, I mean, you as a hygienist and knowing all the inner workings of the conversations that go on and who communicates to who, from your experience, who is best in the practice to present this program to the patients?
I mean, the top practices really have an entire team alignment. It's everybody's brushing with the Zana brush. Everybody gets to share their experience. My favorite offices are the ones where the front office is actually talking to the patients about it. But typically it is the hygienist. They're the ones that are recommending, and prescribing the oral hygiene to the patients. So I would say, the hygienist buy-in with our program is huge. And there is loyalty to brands, as I was also. So it's really understanding that it's not just about the brush, it's more than the brush. And I always tell the hygienists when I'm presenting to them, like, put your business hats on for a moment here and let's look at this program from a business ROI. And I think once they start to realize that, then it's just, they're really able to incorporate into their practice really easily.
Well, and you mentioned it's more about just the toothbrush, and you might not be able to see everybody. Shawnee's shirt, you probably just see stop selling, but I think what it says is stop selling electric toothbrushes. And so I know, like, when we go to these meetings, everybody's like, wait a minute, like, aren't you like an electric toothbrush company? But like you mentioned, and you and Sean have done such a good job of this, it's more than that. I know, just in hearing conversations that you all have with the people at the shows and all of that, it really is about helping these practices stay connected with their patients, building that value added service, and doing something a little different, which is what I loved about you guys.
Yeah, absolutely. I mean, competition is crazy, and practices are having to get really creative with how to enhance that patient experience and how to actually stay connected with them, the 360 days a year that they're not in their practice. Yeah. So, it really just is a win-win. And we're just excited about the ways that dentistry is just going to improve with the program.
Awesome. So can you let everybody know where they can learn more about Zana? Like I said, right below everybody in the comments thread, you're going to see the link that they've provided. So would love to have you click on that, visit their site and learn more about the great work that they're doing. But anything else, Shawnee, as far as like, great place for them to go and learn more about what you guys are doing. I think more importantly, like how they can get started.
Yeah. So obviously the website will have more information. Anyone can reach out to me directly. It's just Shawnee, SHAWNIE at myzana.com if you guys have any questions. But getting up and running is super easy. You let us know what you want imprinted on the brush. We send you the brushes right off the bat. We train your team. So we want you to be successful. You don't just sign up for Zana and then just wonder, how does this work? We have a designated success coach for the practice that actually coaches and consults and trains all of the individuals on the team depending on their role. And we really make sure that it's something that you guys can incorporate long-term and really watch the difference in your patient retention and the production in your hygiene department after you get this program up and running. So yeah, reach out or just on the website and we'll help you guys out.
Awesome. And as you can see, everybody, right below in the comments right now, you'll see both the link to their website as well as Shawnee's email. We went ahead and put that in there. So reach out to her, go to the site, check it out, support what they're doing. They're doing some great work. And Shawnee, I just want to thank you and everything that you guys are doing at Zana. And thank you for taking time today to come on here and share with our audience between their CE courses some of the great innovative things that companies are doing in our profession today. So with that, have an awesome weekend and we'll talk to you soon.
Thank you, guys.
All right. Thanks, Shawnee.
Hi, welcome to the 2021 Academy of Oral Surgery's Fall Symposium. I'm Dr. Kevon Javid, the host of this program. Today, I would like to introduce our special guest, Dr. Kenneth Lee. Dr. Kenneth Lee is committed to creating super dentists. He's currently a practicing dentist in Sydney, Australia, the principal of Today's Dental, which is a multi-location group practice running for over 30 years in the same location, same practice. His personal practice is primarily limited to orthodontics, TMD, sleep medicine, and implant dentistry. Over the past 30 years, he has never stopped furthering himself in these key areas and received many accolades to evidence his mastery and experience. These include by examination, fellowship in International Association for Orthodontics, International Congress of Oral Implantology, American Association for Functional Orthodontics, American Academy of Craniofacial Pain, World Academy of Ultrasonic Piezosurgery, and International Dental Implant Association. Diplomats by examination for International Congress of Implantology, International Association for Orthodontics, and World Academy of Ultrasonic Piezosurgery. He continues to be an active and driven member in numerous international dental bodies, including being a past president and currently the chair of education for the International Association for Orthodontics, the International Congress of Oral Implantology, the International Dental Implant Association, and the World Academy of Ultrasonic Piezosurgery, of which he is a diplomat and international board member. He also sits on the esteemed Global Scientific Dental Council for AEEDC, Dubai. He's a professor of postgraduate studies at Universitat Jomai, where he is currently teaching and supervising postgraduate dental students in the fields of oral implantology and orthodontics. He's a frequent and renowned teacher both nationally in Australia and internationally, whose catchphrase, teaching and treating, is above all, do no harm. He's a founding faculty member of the International Academy of Advanced Dentistry in Sydney, Australia. IAA Dent holds courses approximately 30 weekends per year all around Australia, teaching graduate dentists all aspects of orthodontics, TMD, and implant dentistry. As IADD principal lecturer, he's passionate and strives to bring fellow dentists to the forefront of dentistry, creating super dentists who are enabled to create healthier people with beautiful smiles. His ultimate aim is for the doctors to provide exceptional care for all of our patients and our community. Welcome, Dr. Lee. It's a pleasure to have you.
Hello, everyone. It's good to be back again to speak for the Global Summits Group. It's nighttime here in Sydney, so wherever you are in the world, hello. Today's topic is stress shielding for fixture and for prosthetic considerations to ensure long-term success. My name is Ken Lee. I'm here in Sydney, Australia, and if you want to know a little bit about me, this is my CV. I also have multiple clinics here in Sydney, and we teach. I'm a foundation member of IAA Dent, which is International Academy of Advanced Dentistry in Australia, and we teach foundation courses in orthodontics and implantology. I'm also a professor at Jomai University in Spain, and I teach implantology and orthodontics as well there. We run master specialty programs in orthodontics and implantology, as well as diploma courses. So you can do a basic diploma course in either orthodontics, implantology, or TMD with an element of sleep disordered breathing. So welcome to our very, very short talk. It's an honor and privilege to be a member of the Academy of Oral Surgery. And when we talk about oral surgery, it can be dentoalveolar surgery, it could be implant surgery, it could be regenerative surgery using stem cells and PRP, PRF to help regenerate soft tissue and hard tissue. It could be orthodontic assisted surgery, where we do different aspects of minor oral surgery to enhance and stabilize our orthodontic effects. And that's something which we do very, very commonly in our practice and we teach. The motto of IA Dent is to create super dentists. And so we aim at creating a super dentist that can incorporate both high levels of understanding, skill, and knowledge in implantology as well as orthodontics. A strong young man would have different masticatory forces than an older, more frail person. And so when you plan for a prosthetic aspect of a person, you're not planning the same plan for a young, strong person as compared to an older, frailer person, because the force factors are very, very different. So what I'm saying here is that when you look at the masticatory demands, it's the masticatory demands and the force factors of the patient which get you to plan your prosthetics. And once you've planned your prosthetics, you work backwards and plan your surgery. Okay? A beginner would plan the surgery and then tack on the prosthetics on top of that. A more advanced practitioner would be planning the prosthetics for longevity, good wear, and sustainability, and then working backwards and seeing what surgical steps they need to do to achieve a good long-term prosthetic effect. And this is what we're aiming to do. So when you look at the patient force factors, you have to understand that when you're replacing a tooth, you're not replacing a tooth with another tooth. You're replacing a tooth with an implant-supported prosthesis. So the fact that you've got an implant rather than tooth roots makes a very, very huge difference in the way you plan. Okay? As we know, implants have no ligaments. Ligaments have a high degree of proprioception, have a high degree of basically stress shielding, and has got a very, very high degree of dissipating multi-directional forces. Natural teeth have got that benefit, but implants don't. Okay? Implants prefer to be loaded more axially and less multi-directionally, and because of the lack of proprioception, implant-supported prostheses tend to bite down harder than natural teeth. Natural teeth have a self-protective mechanism, and that self-protective mechanism minimizes any possible trauma and harm to yourself. Whereas implant-supported prostheses don't have those ligaments, don't have such a highly well-defined self-protective mechanism, and it relies purely on bony proprioception. And that bony proprioception is much, much duller. Another way of saying that is that to have a similar proprioceptive effect, biting down on a peanut for 3 seconds, for example, if it's implant-supported, you bite down 4 times harder than naturally tooth-supported. Some other very important factors you need to consider are what we call patient force factors. And patient force factors are things like, if you're replacing one area, what's the opposing dentition look like? Okay? If you're opposing a denture, a removable denture, then the patient force factors will be fairly low. If you're opposing an implant-supported prosthesis, and that's the other end of the spectrum, then the patient force factors will be very, very high, and you need to take that into consideration. So there's not one cookie-cutter formula. You can't say, for example, I'm going to say something controversial, but you can't say every case is an all-on-4. All-on-4 is good in some cases and not good in other cases. And it all depends on the patient force factors and the prosthetic considerations that go with that. If the patient has increased musculature, if they parafunction, if they brux, you need to take that into consideration, and you need to stress shield accordingly, and you need to accommodate this. Males versus females. Okay, typically a male has more musculature and would bite down harder than a female. The size of the head. A bigger head has stronger forces than a smaller head. The age of a patient. Okay, a younger patient would have more active musculature, would be chewing harder foods, would be using their masticated muscles in a more dynamic manner than an older person. We all know that as we get older, a lot of our muscles atrophy. And as the muscles atrophy, our biting force becomes diminished. And so you need to take that. So the age of the patient is important. Okay, when you're planning your prosthetics, you're looking at things like crown-root ratio. What kind of crown implant ratio are we looking for? We're looking at implant position. Is an implant in the lateral seeing the same amount of force as an implant in the canine region? Is an implant in the first bicuspid region having the same amount of force as the first molar region? Obviously not. So you have to be able to strategically plan for optimal loading and stress shielding. We look at things like bone density. Okay, so the softer the bone, the longer it may take for the bone to mature. So you need to time everything properly. So typically and historically is the posterior maxilla and the posterior mandible, where you might leave things a little bit longer and take into consideration that the bone could be a little bit more porous, a little bit softer, more towards type 3 and type 4 bone, and you need to plan accordingly. So the implant size, shape, diameter, and the implant material may be different whether you have hard bone or soft bone. And these are the things you need to take into it. And the last thing, of course, is stress factors. Key implant position for optimal stress factors. There's a reason why we have canine buttresses and first molar buttresses. And so key positions are things like the canines and the first molar. So if a canine or first molar is missing, it should be replaced. I'd go so far as to say it must be replaced for good occlusal harmony. Okay. Some other rules which we talk about are things like Schillingberg's principle, where we have no more than 2 pontics, and other aspects like we try to minimize the amount of cantilever that goes on, especially distal cantilever. Okay. Females have a 20% lower musculature than males. Therefore, because they have lower musculature, there's a lower failure rate. So women, the failure rate in women is much lower than the failure rate in men, and younger people have more bone loss than older people because the bone turnover is much more dynamic in a younger person and continues to slow down as the person gets older. Okay, and the more cantilevers you have, the more bone loss you have, and that's quite. So what's happening is when you have a cantilever, you're having more lateral forces on the implant, and these lateral forces cause there to be bone resorption in an area, and you see that quite commonly. Okay, and of course I said the bigger the head, the greater the force. So masticatory forces are very, very important. And what we want to do with masticatory forces is actually decrease the stress in both the bone and the implant body. So you don't want the prosthesis to fail, you don't want the implant to fail, and you sure as hell don't want the bone to fail. So everything you plan is to plan towards maintaining bone, maintaining implant integrity, and keeping the prosthetics firm and functional. People think that implants fail primarily from hygiene. They usually fail from poor prosthetic planning. In my experience, hygiene is very important, but most implants, if they've been there for more than 12 months or so, they usually fail because of poor prosthetic planning. There's something we missed out there, okay? There is a difference in the chewing cycle and the masticatory forces between natural teeth, someone who's totally dentulous, wearing dentures, and an implant-supported prosthesis. On one end of the spectrum, where you have the weakest masticated forces, are basically a full and full denture. After you've been edentulous for a long time, you have very, very low masticatory forces. And on the other end of the spectrum, if you have an implant-supported prosthesis opposing another implant-supported prosthesis, then those masticatory forces are the highest. It's very common for us when we do an analysis of a patient to do two things. We do an occlusal analysis and a muscle palpation. And these are some typical forms of which muscles we palpate and what factors we look at when we're doing our range of motion and occlusal analysis. Unfortunately, there's not enough time to go through each aspect, but it's worthwhile understanding that before you do anything, you should know as much as possible about how the patient functions. Yep. You have to know as much as possible how the patient functions before you do anything, so there's no surprises down the track. So it's routine in our practice, and it's routine for our students to check with the patient, do an occlusal analysis, check ROM, range of motion, do a muscle palpation to see if there's any trigger points or any hyperactive or parafunctional habits we need to accommodate for. If there's TMD, then we treat the TMD first. Force factors, as I said before, could be things like an opposing arch. The weakest, of course, is a lower acrylic denture, and the strongest force is an implant-supported prosthesis. And so, depending on what you have opposing what you're planning to do, you need to alter your final prosthesis and implant planning. When you plan for a prosthesis, you plan for contour, comfort, function, aesthetics, speech, and health. And these were very, very poignant points brought up by the late, great Carl Misch. Prosthetic considerations. If the patient chews gum, has an aberrant tongue function, is a wind instrument player, has any other kind of oral habit like pencil, pins, object habits, likes to eat super chewy foods, then that would be a relative contraindication to an immediate replacement and immediate loading. So not every case can be an immediate replacement and immediate loading case. So if someone has strong masticative function or has some kind of parafunctional habit which would compromise the initial stability and thus the secondary stability that comes as the implant bone heals up, then it's best not to do immediate replacement and immediate loading. That would bring us to the second stage. And if you needed to stage your treatment, then there will be a period where the implant would be basically integrating and healing in the bone, and you could have a choice of temporary prosthesis. It could be something removable or something fixed. But whether it's removable or fixed, this is what you should be aiming for. You should be aiming for tooth-borne prosthesis, not tissue-borne prosthesis. That's the main point you have to remember. Because when you work, you don't want any pressure on a healing surgical site. You don't want any pressure on a healing implant site, because that kind of movement and pressure could basically deintegrate the implant. So instead of having osseous integration, you'll have fibrous integration. And that would basically be the death of the implant. So whatever it is, try as much as possible not to put any pressure on the surgical site. Try not to put too much pressure initially on the soft tissue. And your temporary prosthesis should be a tooth-borne prosthesis, not a tissue-borne prosthesis. So I'm not keen on flippers, for example, where you have a tooth and acrylic hitting the surgical site during function. That's not a good idea. And people say, well, what are the parameters you would look at for increase? If you have increased patient force factors, would you make the implant longer? Would you make it wider? Well, when you do a search of the literature and you do your research, you'll find that basically both length and diameter help increase the stress shielding, but it's the increase in width, it's the increase in diameter that has the most profound stress shielding aspects. So if you're aiming to increase the actual stress shielding of an implant and the load-bearing capacity of an implant, my advice is not just look at length, but look at width. Okay? Because if you look at the length of the implant, the crestal portion, the apical portion, it's the crestal and apical portion that actually bears most of the stress, and the in between the crestal actually has very little. So it's not the total surface area and the length you're looking at, but the functional area. So width actually has more functional area than length. And there's been a lot of research over the years looking at that. And this is all here in this slide, but basically it's saying the same thing. Also have a look at the thread patterns of the implants you're using, and the thread patterns will tell you the ability of the implant to distribute the forces well. Okay, so the old-fashioned triangular screw thread may not be the best for stress distribution. Maybe a square thread or buttress, whether it's a regular buttress or a reverse buttress, may be better at stress shielding and distributing the forces. Okay, and Mish, of course, did some study, and basically you're looking at the functional surface area, and the functional surface area is a result of both length and width, but width is the most important. Okay, so functional surface area is very different from total surface area. Okay, another aspect you would look at is an abutment connection. Okay, so an abutment connection is where if it's a two-pieced implant, in other words, a bone level implant, then the connector will tell you how well that can stress shield. So whether it be an external hex or an internal hex, how tall the external hex may be, these are all factors which basically tell you the ability of how well the stress shielding is. So the other aspect which we like to talk about is screw versus cement retained. Now, in the old days before Brånemark, there was a high incidence of cement retained, and then when Brånemark came along, then it all shifted to mostly screw retained. And now we're looking at it and we're thinking there's actually advantages and disadvantages of either. And so we teach all our students to think critically as to which will be the best prosthetic option for that particular patient. So there are advantages in cement retained and there are advantages in screw retained. And you need to be able to differentiate what you need for your patients. So as I mentioned earlier, key implant positions is important, canines, first molars, as well as general rules such as try as much as possible not to distal cantilever, especially in the posterior maxilla, posterior mandibular region. Little hints which we have is things like try to have, if you have terminal ended implants as part of a multi-unit bridge, for example, then what we would try to do is have the implant basically in line with the distal marginal ridge of the terminal end. And that helps avoid any kind of seesaw effect, which is also an unfavorable force. A seesaw effect is like basically a cantilever, and the cantilever puts lateral forces on the implant. So Schillingsberg's principle basically says that it shouldn't have more than 3 adjacent pontics. What it boils down to is that a 3-unit bridge has a lot less flexure than a 4-unit bridge. And a 4-unit bridge has a lot less flexure than a 5-unit bridge. So the longer the span in between the two implants, the greater the flexure there is in the bridge, and the greater forces there are on the implant as well as the prosthetics. So you have a prosthetic failure, and you could have an implant failure and bone loss. These are things you need to keep in mind when planning. So some people say, well, I don't use metal, I use zirconia. Well, zirconia has its own set of problems too. You should still try and avoid long span bridges with more than 2 or 3 pontics for zirconia. So try not to do this, where you have the central and the basically the first molar as the 2 abutments, and then everything else is a pontic in between. And you try not to go around a corner. So if there's a canine missing, you replace the canine. That's a key position. Yeah. So when we talk about key positions, basically, if the arch is edentulous, then you look at basically 2 millimeters mesial to the anterior aspect of the anterior loop or the foramen, and you divide it into 5 distinct areas, and we call that A, B, C, D, E. And you put these implants in the A, B, C, D, E area if there's insufficient bone posterior to the mental foramen. For the uppers, we put implants in the key positions as well as wherever you need it to keep the principles of key positions, no more than 2 to 3 pontics, and minimize distal cantilever. Remembering that the bone in the maxilla is very different from the bone in the mandible. So the bone here is usually much harder than the bone here. And so you may need to put more implants in the upper arch than the lower arch to achieve a similar result for stress shielding and load-bearing capacity. Same with mandibular overdenture planning. Never haphazardly put implants anywhere there and just say, oh, I'll just put 2 implants and do an overdenture. Because later on, you may want to add more. And if you don't put the implants in the key position, basically you've condemned the patient to not have optimal treatment, because they might come back 2 years later and say, my situation has changed, doctor, I would like to have more implants, or I'm not happy with just 2 implants, I still have a bit of movement, I'd like to make it firmer, I want to put more implants in there. And if you didn't put the implants in the correct position to start off with, then basically you may have to start all over again. And that's just poor prosthetic planning and poor implant planning. So this comes from Mish's book, and if you're interested in that, I suggest you read it. It's a great read for prosthetic planning. For cantilevers, there are general rules, and the general rules in the mandible is if there are 4 implants, then you can distal cantilever 1.5 times the distance between the middle of the most anterior implant to the distal of the most posterior implant. Yep. If you have 5 implants here, then you can actually cantilever more. You can cantilever 2.5 times from the middle of the most anterior implant to the distal of the most posterior implant. And if you stick to those rules, you should be all right. Arch form. So another important consideration is arch form. So dependent on whether you have a U-shaped, a V-shaped, a square-shaped jaw will dictate how many implants you need to maximize stress distribution. That's why I was saying in the very beginning, do not adopt a cookbook approach to implant placement, okay? Because you're going to get into trouble long term. Every implant placement you do is based on, firstly, what the patient wants, secondly, what prosthetic considerations you need to do. So your prosthesis comes first, and then you go backwards and plan what surgical implants you need to put in there to achieve that prosthetic result. So the things we look at once we've got the prosthesis on, or once we're planning our prosthesis, is you want to have no premature contacts, okay? No premature interferences. So when you occlude on an area, there should usually only be 1 point contact. It's not like a natural tooth where you can have 5 to 7 point contacts. It's just 1 point contact, and it should be an area, not a point. It should be down the long axis of the implant, and there should be no lateral excursion contacts, whether it be side to side or front to back. When checking your occlusion, we typically have different colored articulating paper, and we use one color for centric occlusion in both the upright position as well as in the supine position, and that's to mimic daytime function as well as nighttime function. We use a different colored articulating paper for lateral and excursive movement, and when we check the bite, the centric and the excursive movement should be in one position only. The different colored articulating papers should match. Anywhere there's a non-centric marking on from the articulating paper, we treat as an interference because that would basically correlate as a lateral force. We want to minimize the surface area of the prosthesis because it's basically force per unit area, so we're trying to minimize it. We want the cuspal inclines not to be too steep because the steeper you have the cuspal incline, the more lateral forces you would incur upon the implant. So you want to have a less steep cuspal incline. You want to minimize too many angled implants. Okay, you try to minimize the number of cantilevers you have, and you try to get the crown root ratio as much towards 1 to 1.5 or 1 to 2. Okay, you want the contour, you want there to be basically more towards under contouring, not towards over contouring. And the materials of choice is obviously metal has the best stress distribution, followed by PFM, followed by pure ceramic. So when you look at the masticatory cycle, you want as much as possible for the force to go down the long axis of the implant. That would minimize lateral forces. Yep. And anytime the patient goes into an excursive motion, there should be a disclusion in that area. So they shouldn't be able to go and actually touch all the way along. When choosing an implant, you need to choose an implant which has characteristics which basically help distribute the load and maintain the bone level as well as keep the prosthesis in function. So things like external versus internal, there's a difference. Connection. The actual, for external hex, the height of the hex is important. For internal, the amount of remaining metal around the internal connection is important. So whether it's a hex, whether it's a tripod, whether it's conical, these are all considerations which you need to take into account when planning your prosthesis because each of them have different stress-bearing capabilities. And when you put a load on, then you will have continual stresses on the implant. So if you look microscopically in the implant during function, the whole assembly actually bends. So it's not solid, it actually bends. The whole assembly bends. And it's the multi-cyclic, thousands upon thousands of cycles of these bends that could cause for example, the abutment screw to loosen or to break. And so you need to keep that under consideration. Yep. So that's part of your consideration whether you want to have the stress breaker as the screw, as the abutment screw, like a screw retained in prosthesis, or you want the stress breaker as the cement, whether in the case of a cement retained prosthesis. You may want to decide to use a weaker cement rather than the stronger cement initially. You may want to steer clear of composite resin or glass ionomer based cements because they're near as impossible to remove once you've cemented it. And using glass ionomer or composite based cements do increase the incidence of mucositis. And so you have to be very, very careful and cautious if you are to use that. We don't recommend that you use it. Try as much as possible to have axial loading. If you don't have axial loading and you've got excess lateral forces, you'll be left with things like saucerization, where you have bone loss, where you're supposed to have the most amount of functional surface area, you actually get bone loss, and that's called saucerization at the crest of mainly at the crest of the implant, the crestal portion. You want to minimize lateral forces because they cause a bend. The bending forces are due to excessive lateral forces, and that has the effect of losing bone, loosening the screw, or breaking the screw. So all not good things. As much as possible, try not to cantilever too far back. If you do need to cantilever, have the abutments where the masticatory forces are the strongest, and have the cantilever pontic in an area which has the least amount of masticatory force on it. So how to decrease bone loss around implants? Number one, have enough implants to handle the load. Number two, make sure the implant has a good size, whether it's length or diameter, knowing full well that diameter is more important than length. Implant design. What kind of implant have you got there? Okay, is it external hex? Is it internal hex? What's the thread pattern like? Yep. What kind of connection have you got? Yep. What's the surface treatment? So surface treatment plays a role, more so in early loading than in later loading. Past the 12-month mark, it's not so important, but for early loading, surface treatment is very, very important. Okay, of course, implant position is crucial. You need to plan to put the implants in the strategic areas which handle maximum occlusal loads. Yep, and then we look at the patient, what we talked about before, patient force factors. Interesting research from OSTEM was that for a regular, as you can see from the OSTEM research, the wider the diameter, the greater force distribution there is, and the less deleterious effect there is on the bone. If you consider a regular implant and as 100%, if you put two regular implants together and splinter them together, they increase the force capability of the prosthesis by 170%. If you put two narrow platform implants and splint them together, it increases the force factors by an extra 140%. But if you put a wide platform implant in there, then it increases the force capability of the implant by 180%. So you can see that diameter is very, very important. Abutment angle plays an important role too. So try as much as possible not to put too great an angle on the abutment, because the greater the degree of abutment offset, the greater lateral forces you're placing on the implant. Cuspal inclination, very important. You want to minimize cuspal inclination to decrease lateral forces. A linear configuration tends to be weaker than having a tripod-like configuration. So as much as possible, when you're planning your surgical aspects in line with your prosthesis, try to place an implant in an offset position, and that will increase the force distribution of the masticatory forces upon the bone via the implant. Okay, very interesting research showing basically that whether it's splintered together, whether it's single implants in line or in offset, it's always offset that has less force, and splinting together is an advantage. So as much as possible, try to splint. Stress levels change depending on whether you have 2 implants or 3 implants, whether you have an offset or non-offset. Okay. Splintered teeth show less screw loosening than non-splintered teeth. Wider implants show less screw loosening. Okay. Wider crowns have more crown screw loosening, because the greater the surface area, the more force per unit area, and the more lateral forces there could be. And that's why we should be minimizing the size of the prosthesis. And if you can't minimize the distomesial length of the prosthesis, you can always minimize the buccolingual width of the prosthesis. And that's what we try to do. When we try to minimize surface area, sometimes we can't really decrease especially with a bounded saddle, we really can't decrease the mesiodistal distance, but we do try to decrease the buccolingual. So basically we try to minimize the surface area so it's less force per unit area. Options for occlusion. So when you're planning your occlusion, you have to decide where you want to finish the patient off. And there are different forms of occlusion, but you've got canine guidance, group function, a balanced occlusion, or anterior guidance. And be very, very careful when you plan this, because, for example, the musculature is at its strongest when you have canine guidance. The musculature is at its weakest when you have anterior guidance. So you need to decide as a clinician what kind of musculature you want for your patients. It may be advisable to give them something to wear in the nighttime to take care of any parafunctional activity which they may have. Okay? Mish talked about this very effectively, and it's basically a screw down technique, and the screw down technique helps maintain the integrity of the actual screw down of the abutment screw. And what it does, the way it's explained is, as you screw it down, there's a microscopic loosening of the screw and a little bit of jiggling going on within the assembly. And so you have to give it enough time to work out all the stresses and a little bit of loosening, a little bit of jiggling going around, and then screw it down again. You want as much as possible to have a firm adaptation, which is very difficult to unscrew for the abutment screw. And as I've been saying during this whole talk, plan backwards. Look at the patient force factors, plan your prosthesis, then determine where the implant should go, keeping in mind the patient's force factors and the prosthesis you're going to use. It's been a pleasure. I look forward to your questions, and I hope to see you sometime in the future. If it's someone who's listened to me before, great to have you back. If you've never listened to me before, then it's nice to have met you. Thank you very much.
Hi, welcome to the 2021 Academy of Oral Surgery Fall Symposium. I'm Dr. Kevon Javid, the host of this program. Today, I would like to introduce our guest speaker, Dr. Ahmad Saloom. Dr. Ahmad Saloom graduated from the Dental School, Damascus University in 1981, where he completed his residency program at Damascus General Hospital and board certified in oral maxillofacial surgery in 1986. He also attended an externship training at Emory University and Emory Clinic in Atlanta, USA in 1989, 1992, and 1998. He's also a diplomat and ambassador of ICOI, an ambassador of Digital Dentistry Society. He's a board member of Syrian Association of Oral Maxillofacial Surgery, an elected editorial board member of Syrian Association of Implant Dentistry. He's a speaker and director of advanced surgical implant courses for British Academy of Implant and Restorative Dentistry. Had been a speaker and general course supervisor for Dentsply Trident and Neos implants. He's also an international expert on dental XP. Dr. Saloom had been lecturing in several regional and international conferences and published several posters and clinical studies. He's a chief surgeon and director of Saloom Dental Clinic and Training Center in Beirut, Syria. Welcome, Dr. Saloom. It's a pleasure to have you.
Good day, dear friends and colleagues around the world. My name is Ahmad Saloom. I'm a consultant oral maxillofacial surgeon. It's a great pleasure for me to be with you today to share with you my topic about complications versus mistakes in immediate implantation. As we all know that immediate implant placement protocols are the most technique-sensitive protocols with highest risk of complication and extreme aesthetic compromise, and even a complete failure in some cases. So, during my presentation, I will go through a 20 years retrospective review of some of the complications and mistakes that I faced in my private practice. We all know that immediate implantation started as early in the late 70s by Professor Schulte, placing a root form of old ceramic implant, which was called Tübingen implant, and modified later in the 80s to be a stepped conical titanium implant manufactured by Friatic Company, and it was called Frialit 1. Professor Schulte suggested guidelines for immediate implantation. The first thing is using a tapered step implant that fills all the entire cross section of the socket. So it has to be with the same shape and form of the root, tapered shape, and filling all the socket, so using a big size implant that fills all the socket, and the entire cross section should be filled in a way that it will give more stability, and this will support and preserve the alveolar prominence according to their understanding at that time. Same publications were published by Yuri Grunder, Giovanni Policy, Ramon Gomez, and Professor Schulte, Richard Lazara. They stated that they had a high success rate with immediate implantation. Same suggestion about the guidelines for the immediate implantation was published also in 2001 by Team Atlanta, Henry Maurice Salama, and David Garber, and they recommended using a wide diameter tapered shape fixture implant that will optimize the success. And they suggested that if we can do it without incision, and they called it incision-less approach, it will be more preferable. A controlled clinical and histologic study in man was done by Andriano Piatelli and his co-workers. They stated that the clinical outcome and the degree of osseointegration does not differ from implant placed in healed, mature bone, or if it's placed immediately. So they gave us a very good hope about the immediate implantation, which was a new era at that time. Paolo Antonio and Piatelli also, they concluded that immediate implants is described to avoid the negative effect of extraction, with absolutely no statistically significant difference between implants that were placed in fresh sockets and the implants that they were placed in a full mature bone, rather in the maxilla or in the mandible. In another study by Stephen Chen and his co-workers, he concluded that short-term survival rates and the clinical outcomes of immediate and delayed implantation were almost the same and comparable as a final result. All those studies was really very encouraging for us as clinicians to start doing the immediate implantation and to be thinking out of the box with this which we were trapped for years with the mentality that we used to practice in our implant therapy. Well, this is one of the very early cases that I did in 2003 for immediate implantation. The patient came to me at that time with the unrepairable remaining roots. So I suggested doing her implants, and I placed it immediately. 4 years later, all implants were osseointegrated and the cemented prosthesis was done with a very nice and satisfactory result. The patient was happy and I was happy for the one of the first cases success with immediate implantation. In a 2 years follow-up, the patient came to me for a routine follow-up, so I took out the bridge, which I usually, until now, if I'll be using cementable cases, I always use stem bond material with a temporary cement, so I'll be able to retrieve my bridge and check on my implants. Anyhow, after 2 years, the patient came complaining of pain and tenderness with exudation around implant placed in the left central incisor area. Also, the X-ray revealed bone resorption in the distal and labial region. In fact, this implant was lost at a later stage, and a new bridge on 5 implants was refabricated. At that time, I thought to myself, why did I lose this implant after 2 years with success and also integration? According to our knowledge at that time, I thought that it was maybe the zipper effect, which was told by Carl Misch, that the stresses at the crestal bone may cause a microfracture, and those microfractures led to a kind of a resorption. This is another case done at the same year. My second case, it was following, as you see here, unrepairable, unrestorable central incisor. I did an atraumatic extraction and placed my implant according to the protocols to fill the whole socket, trying to use all the knowledge that we have at that time. So I placed a 4.5 millimeter diameter implant. 4 months later, we can see excellent healing, and the labial contour is very nice. And when I placed my final prosthesis, I discovered about a 2 millimeter recession was encountered that shifted the zenith line to an apical position. Well, that time I thought to myself, where are the promises of Paolo Antonio and other co-workers? So all our dreams of immediate implantation to avoid all the negative effect of extraction has gone in vain. And we started to think that all those thoughts, maybe they are not absolutely correct. In fact, Arujo and Linda, they stated in 2005, I mean now 3 years later or 2 years later, that the bone resorption and the gingival recession is not avoidable. That is, even if we placed the implant at the time of extraction. So, according to the new looking and the new research, they thought that maybe raising a flap is one of the main causes of labial or labial recession, the labial bone recession, and is the main cause of gingival recession. And the new error was done to start doing all our immediate implantation as a flapless approach. And this was documented by Bellem and others that the flapless approach for immediate post-extraction will reduce the buccal bone plate resorption. So I followed the same protocol, and I wanted to be up to date at that time, so I started doing immediate implantation as a flapless approach. And this is, I think it was the first case that I did flapless of immediate implantation. This is a non-restorable remaining root, which had a post and core before with a crown. I did an atraumatic extraction. I placed my implant according to the protocol, filling the whole socket as much as I can with a high primary stability. And the final result and the healing process was really uneventful. The healing was very good, and we can see the contour after 4 months of the gingiva was great. And 4 months later, we placed our final crown, as you can see here. And the patient was satisfied, and she was happy that we made the immediate implantation, and we gained about 4 months of time. But if we take a very good look, if we retract the lip, I think that I have lost 2 more additional, or between 2 or 3 millimeter of gingiva and bone. And thanks God that the patient had a low lip smile line, and this area was covered, even it was masked with the pink porcelain. So if we compare where I started with this case, of course it has a compromised zenith line due to the crown and the porcelain core that was placed before. But even after immediate implantation, I had much more recession. In 2004, this is one of the my nice cases at that time that I suffered for years and years to solve. This patient came to me with a fractured teeth, and those were unrepairable, and we decided to do immediate implantation as a flapless approach. After a traumatic extraction, as you can see, I placed my implants in the empty sockets with a good primary stability according to their prosthetic guide. The healing was nice and uneventful, as you can see here. Sorry. The gingiva and the contour was good, but when I tried to place my final abutments and the crowns, the final outcome ended with black triangles and loss of my dental papilla. Well, the first brainstorming study was done by Boozer and Belzer, which was published in 2004. This was brainstorming that opened my eyes to the main cause of labial bone resorption that occurred when the implant was engaging the buccal plate. And this study really opened my eyes to the new way of placing my implants, that the implant should be at least 1 to 2 millimeter palatal of the emergence profile of the adjacent tooth. In other words, any implant which is touching the labial plate, definitely it will cause it now, or it will promote bone resorption, and it will be and you will face a kind of complication. And we all remembered with his research, he gave us guidelines how to place the implants according to the bone and the adjacent teeth. Another brainstorming study was done by Howard Glockman and Jonathan Dutoit in 2005, where he stated that the concept of filling the socket with the implant in immediate protocols is now well known as wholly incorrect protocol. And many techniques that we used in the early of the 2000, between 2000 and 2003, were mostly neglected now in 2005. So all what we did before was totally a mistake. When I read those papers, I had to go back to my previous cases that I showed you before to see what should have what shouldn't be done to avoid the complication. This is the case that I lost the implant, so I went back to the surgery photos, and sorry, that was the technology for the photos at that time. So I should have placed my implant. Look at the other implants, they were just accidentally had a more palatal direction, except this implant which I lost. I should have placed it a little bit palatally before. So in other words, I should have shifted a little palatally for this case too. Going back to the research that had been done by Boozer, in fact, he gave us a full protocol or a full guideline for placing our implants in the three-dimensional positioning, either buccopalatal, mesiodistally, and apicocoronary positions. Since then, I think that we shifted totally to a new protocol or a new way in placing our implants. A very interesting and very valuable study was done by Team Atlanta and published in 2007, which showed clearly the ideal implant positioning in a four-dimensional perspective, mainly in the aesthetic zone. Since then, a total shift had taken place in the concept of placing the immediate implantation. So we started to place our implants in a palatal position. Going back for reviewing the case I showed you before for the two adjacent implants, trying to find an explanation for what happened and why did I have bad aesthetic results with the black triangles. The first article that I read searching for a solution was the new article that was published by Dennis Tarnow in cooperation with Team Atlanta, Team New York and Team Atlanta. And the results showed, gave me a very good explanation. This paper explained the whole matter about the importance of the implant positioning in the coronal apical plane that determines the distance which is necessary to preserve the dental papilla, which has to be 5 millimeter. And I think that all of us have read this valuable article. In a shocking research also that I read in 2010, a conclusion that flapless implant placement into extraction socket did not result in the prevention of alveolar bone resorption and did not affect the dimensional changes of the alveolar process. So it's not a matter of raising a flap or non-raising a flap, but still all the other papers would recommend to do our implants for the experienced guys. If there's no possibility for bone augmentation, as much as we can, that we don't raise flap. So going back to this case that I showed you with the black triangles, this is the panoramic x-ray. As we can see that the implants may be somehow kissing each other at the apical level. So and this is a magnification with a small x-ray. You can see what's wrong with my placement is that I placed the implants only 2 millimeters apart. They should have been 3 millimeters apart, with a 7 millimeter between the contact point and the bone. And this is totally incorrect. I should have shifted my implants during placement as a 1 millimeter apart from each other, in a way that I should have a 3 millimeter between the two implants, and I should have placed my implants a little bit deeper in a way to get only 5 millimeter between the bone and the contact points of the crowns. And this was my mistake at that time. How did I solve the problem? In fact, the only solution I had is to change the abutments with the narrower abutments. I did a switching platform in a way that I give more space at the platform plane, and started to say all my prayers, aiming to get a creeping papilla by time. In fact, during the coming years, I had a better result, and I had a creeping papilla, and this is a follow-up for 2-3 years, and this is a follow-up for 5 years. At that time, when I had the chance to be in 2014 at the BioHorizon Symposium in the United States, I listen to very interesting presentation and a clinical study from my dear friend Maurice Salama about the central lateral dilemma. And he suggested in those kind of cases, and he suggested placing just one implant holding a cantilever pontic with a soft tissue augmentation in the pontic area would give much more aesthetic result, and this method is very reliable. Things stayed almost stable with the flapless approach and correction of our previous mistakes until 2012, where Team Atlanta and Team New York made a very nice study about the dual zone therapeutic concept. That means after we place our immediate implantation, we should fill the whole gap with a bone graft material, and our grafting material should extend to the level of the soft tissues. So placement of the graft to fill the gap and extend to the zone above the implant abutment interface. And this might provide support and will maintain the volume of the hard and the soft tissues. Since then, we started to follow up with this concept. Another study also was published in 2014 by Team New York and Team Atlanta, and it was a retrospective study that showed the effect of the bone grafting of the dual zone technique, either if we place a temporary abutment, temporary customized healing abutment, or without leaving just a regular healing abutment. It was a very nice study comparing placing immediate temporization or not. The same study was done, the same results at the same year was done by Cardapoli and his co-workers, that showed also the importance of filling the gap and covering the defect with either a custom-made healing abutment or a temporary restoration, as this will considerably limit the unfavorable alterations of the bone and soft tissues around following immediate implantation. This is one of my cases done in 2014 with the dual zone therapeutic technique. As you see, I placed 3 implants, taking all the guidelines of points placing in the 3-dimensional correct positioning. As you can see, after placing the implant, we fill all the gap with the bone graft, and we extend the bone graft level up to the to cover the abutment implant interface, and then placing the temporary customized temporary crowns over the implants. 4 months later, as shown on your left, you can see that some remnants of the bone graft material are embedded and integrated into the soft tissues with nice aesthetic and maintained bone and soft tissue even after 5 years. And this is after 5 years, all the contour of the bone and the soft tissues was really maintained. The part 2 of the same published paper was published 1 year later in 2015 with a study. The same study was completed comparing the flapless implant placement alone with or without a bone graft, and with or without a temporary crown or a custom-made abutment to seal and to block the grafting material. This is one of my cases, and we can see that the dual zone technique clearly here. I placed my implant in the correct 3-dimensional positioning. We fill the gap with the grafting material, and the grafting material should extend to the level of the over the implant abutment interface, and the custom-made healing abutment, if we cannot place a temporization for our case due to the lack of the high initial stability, so we can place only a temporary custom-made healing abutment, and we can see 4 months later a very good healing, and the contour is great. This is at day 0 when I place my final crown, and this is 3 years later. You can see that the contour and the level of the bone and the soft tissue was totally maintained over years, and I saw the patient even after 7 years. Everything was, I think that you can really appreciate the final outcome of the dual zone technique method. All the past cases, I had almost a normal socket, but well, what about immediate implant placement in a compromised labial bone? In compromised socket with compromised labial bone, which we call now the type 2 sockets cases, where there's a labial plate deficiency. This is a great study done by Dennis Tarnow and Team New York, ended to a conclusion that placing an absorbable membrane with the bone graft and the custom healing abutment at the time of flapless anterior tooth extraction and immediate implant placement in type 2 sockets, it can reconstitute the absence of the labial bone plate and maintain the gingival architecture with satisfactory aesthetic results. So even if we have a problem or a resorption in the labial plate, we can still place our implants immediately and place our bone graft, and then we a temporary healing abutment customized, and we get very good results. Of course, the same. But what about if we have another article? This is also done by Dennis Tarnow, Team New York, classifying the labial plate dehiscence and focusing on the subclassification and clinical management of the extraction sockets with labial dental alveolar dehiscence defects, that will put and they put the guidelines for this type of sockets, the class 2 sockets, and they subclassified it for A, B, and C, and they put a protocol how to place our implants in those kinds immediately in those kinds of cases. This is a type 2 sockets, class A. Sorry, one of my cases, and you can see this is a typical one for immediate implantation, where I had about 3 millimeter deficiency in the labial plate. So we have to raise a flap here to be sure of our bone graft material. I placed my implants according to the protocols of Danny Boozer and Team New York and Team Atlanta of the ideal positioning of my implant, and the remaining part we have to do a bone grafting material. We use the GBR technique, placing the membrane, fixing the membrane, and the 1 year follow-up, we can see that after delivery, at the time of delivery, a very slightly compromised zenith line was observed, and it was masked a little bit by a pink porcelain. But this case remained stable over years, and we can see that the follow-up for 3 years, it was stable with a good aesthetic result and no change in the zenith line plane. This is a 5 years follow-up and still with stable and good aesthetic outcome without any alterations in the bone or gingival plane. So But what about the cases? This is another more advanced case of type 2C with total labial bone loss, which I tried to treat accordingly, according to the same protocol that was done at that time. Believing somehow in myself that I'm a good surgeon and I have the confidence that I can build the bone. So I used the same protocol, atraumatic extraction. This is very slight atraumatic extraction, and this root was easily removed. And I placed immediate implantation, my implant, and as you can see here, there's a big gap and a big loss of the labial plate. But as I told you, I thought that I'm a very good bone builder. So I placed my bone graft material, and I added a sticky bone graft material with a PRF, and I used all the technologies that I had at that time. And the final result, and I placed my membrane with the dense, slow absorbing collagen membrane, covered the graft, and with additional PRF, and the case was left to heal for a later stage protocol. 6 months later, a very nicely fabricated all ceramic prosthesis was delivered. But if we take a good look, if I lift the lip up, this will show soft tissue deficiency with compromised aesthetic result, even with added pink porcelain to mask this compromised aesthetic outcome. I was lucky too that the patient has a very low lip line, and she's one of my friends. She is my anesthesiologist who I work with in the hospital, and she accepted the situation because she has a very low lip line. But this complication shocked me and spinned my mind. And I told you that lucky me that the patient was satisfied because she had a low lip line, and she didn't ask for any more other treatment. At that time in 2014, when I was at the AO in Rome, I remembered what the great Dennis Tarnot said, and he ended with a solid conclusion when he said that no buccal plate, that means no implant. And I realized that losing the bone and the soft tissue in the past case wasn't a complication. It was my mistake because I placed my implant immediately. And he kept walking all over the 3 years of the conference. If you go and shake hands with him, he will tell you no buccal plate and you have to answer no implant. And this was his statement after years, his great years of experience. And the same results was found also with other articles like Chapwit. He published a very good article in 2015 that it's much better for us to leave the implant placement for a little delayed stage after 4 to 8 weeks, as the bundle ball will resorb, and the soft tissues will spontaneously heal, and this will give us about 3 to 5 millimeters of additional keratinized mucosa in the near future after a delayed implantation. And this will give us not only 3 to 5 millimeter, and a study by Chapi showed that they recommend the 4 weeks delay in implant placement at the early stage. This will enhance about a 7-fold increased keratinized soft tissue. So, for me as a good and nice clinician, so I followed the same protocol. And this is a type 2C with absence of a labial bone. So I learned from my previous mistake, and I let this case to heal for 4 weeks. And that's what I did. So after 5 weeks, I placed my implants after 5 weeks. And you can see with the CBCT image, this is 3D, the total loss of the labial plate. And I had some of the palatal plate, as you can see here, the cross sections of the implant. But believing in myself as a good surgeon, this is the overconfidence sometimes, the implant was placed in 100% correct 3D positioning, and I used all the tools that I had, also densification, utilizing Dentivers and placing the best position as a 3D, putting my titanium mesh membrane, and I covered the area with the PRF membrane and the collagen membrane and let to heal for about 4 months. In the meantime, I placed a resin bonded temporary prosthesis to let the soft tissues heal well around my implant site. And this is a post-op, immediate post-op. After 4 months, the CBCT revealed very good bone healing and the very good bone thickness, as you can see, and if you compare it with the last CBCT. Unfortunately, after 30 months, the patient came back to me, and I realized that I had a kind of depression in the labial contour. And this is it was a very unlikely surprise to see some kind of resorption at the labial plate. So I started to look at the literature to find an explanation. And one of the factors that I read, it was by dear Joseph Kahn. He said that facial recession will be more pronounced if we have a thin biotype rather than a thick biotype gingiva. And at that time, before what Joseph Kahn stated, we didn't even pay attention about the thickness or the importance of the thickness of our soft tissue material. And he stated that a connective tissue graft at the time of the immediate implant is mandatory. And this was published in 2005, and we missed this understanding. The same, searching for more articles, Boozer and his co-workers in 2015 found that in the thin biotype patients, additional surgical intervention may be necessary to enhance soft tissue's architecture, either during or after implant placement at a later stage. So this is very important in those cases where thin biotype. The same findings were recommended by Howie Glockman and Jonathan Dutoit for the necessity of additional soft tissue augmentation around immediately placed implants. So in those cases where we have a thin biotype, we should always consider not only bone graft material, but we should consider a soft tissue augmentation protocol for more aesthetic satisfactory outcome. The same was and according to this, we have to do a connective tissue graft to solve the problem, or use a pedicle graft according to Edgar Shahar and his co-workers at the time of immediate implantation. And this is an example that I did after 3 years recall for this patient. You see the depression here at the over the crown. Just simply after 3 years, I did a connective tissue graft, and you can see the massive aesthetic improvement after performing the soft tissue augmentation. And I was happy with the final result, and the patient was more than happy too. So in those cases, we needed really a kind of soft tissue augmentation. If we compare, now one of the most profound techniques is the surgical veneering technique, which is a new technique aroused to overcome the unfavorable aesthetic results following immediate implant placement. And this is done by a combination of Team Atlanta and the Agnini brothers, where they recommended additive veneer bone grafting to the labial area, augmentation simultaneously to cover all the and covered again with the soft tissue graft. Showing this case, this is one of the early cases that I did for veneer grafting. The patient had an unrepairable lateral incisor, a traumatic extraction. I had to minimally raise a flap just to make the photos, but all the implant procedure was done flapless, placing the implant and with the one abutment one time, and this is the veneer bone graft material was placed over the area with the collagen membrane and the soft tissue connective tissue graft. 4 months later, we can see after placing the final crown, very good result. This is 18 months follow-up, and this is a 30 months follow-up with a stable, and you can see the stability of bone and the soft tissues. So it's a reliable method. It's a very reliable method for immediate implantation. But one of the most amazing new innovations, I think, is the socket shield that was first presented as early as 2010 by Marcus Horsler as a new concept that will preserve the labial bone and the soft tissue contour even after placing immediate implantation. Horsler and his co-workers published also in 2015 a very nice histologic and clinical and volumetrical pilot study, observation after separation of the buccal tooth segment, which is called the root sanctioning, or what is called the socket shield. The tooth segment showed healthy periodontal ligament on the buccal side, with a new bone formation was visible between the implant surface and the shield. So it's a very promising technique, and this innovation also was adopted by my dear friend Howard Glockman, and he made a PhD study on this on this technique, and he innovated a special instrumentation for it, and it's called the root membrane or root shield or the socket shield. All are the synonyms that describe the same concept. So leaving a small labial part of the tooth, I think most of you are aware of this technique that I started using. This is my first case of the socket shield in 2016. And I think that you can see from the CBCT shows a total absence of the labial plate. So it's a type 2C socket by all times. After doing the root sectioning, I placed my implant in the correct 3D positioning following the partial extraction therapy rules and the 3D positioning of the implant. This is that the CBCT shows stability of the labial plate around implants at 20 months post-operatively, and then at 3 years post-operative we can see all this stability. And this is a clinical photograph for the same patient 5 years later follow up, and you can see the stability of the result. Thank you, Dr. Howie Glockman, for giving me the chance to be one of the first who received his partial extraction therapy kit that done by Megagen Company, that will make the procedure more reliable and more predictable and more reproducible, especially for the new generation of dentists. Another case will show the full protocol of partial extraction therapy and the socket shield after removing the palatal aspect of the root, drilling and placing the implant at 3 mm palatal to the shield. And this is very important to follow all the protocol of the socket shield, filling the gap then with bone graft material and covered with the membrane, with the PRF, and then I placed my abutment, one time concept, as you can see here, and an immediate non-functional temporization was delivered to the patient. At a 1 year follow-up, you can see the stability of the contour, stability of the bone, and stability of the soft tissues. This is even 3 year follow-up, same stability of the labial contour. More studies were now published on the socket shield concept with proven excellent results. All the studies done by the pioneers of the partial extraction therapy revealed very high success in maintaining the bone and the soft tissue in immediate implantation. But within the limits of the indications, of course, partial extraction therapy, or what we call PET, will decrease the need for extensive bone and soft tissue augmentation to achieve stable long-term aesthetic results. And this is one of the high advantages of this technique. It will reduce the possibility for more bone grafting material. And those studies were done with very high success, and the super amazing study group was invented of some of friends from Dental XP experts are now working, and they worked on 10 years of a multi-center clinical study on partial extraction therapy, and the result was published really last year in 2020 with a lot of success. To reach my final step of my presentation, as we noticed that our experience in immediate implantation had gone through numerous complications, bouncing results, pitfalls, hiccups, mistakes, and sometimes failure due to the lack of definite information at the time being. And continuous research through past years led to dramatic changes in the new understanding to biology of the bone and the soft tissue healing around implants, and all of them, they led to new innovations and new protocols throughout those years that made immediate implantation more and more predictable therapy. So, despite that we may have a past long history of successful immediate implantation or implantation, we discover that as we climb up with our learning curve through the years and gain more knowledge and experience, we became more capable to define a new cutting edge in our understanding of complications and failures. And we discovered that most of those complications were really a sequence of unintended mistakes at that time. So I would summarizing that as per of the new up-to-date guidelines, we can, in other words, say the complication of yesterday maybe is a mistake if we do it again today. My conclusion is that immediate implant placement, they are one of the most technically sensitive protocols, with all those dramatic changes have been taken in the techniques and the concepts and the guidelines through those years. And I told you, as we climb with our learning curve, we become more able to define this cutting edge. My take-home message is learning from our mistakes is the first. We have to acknowledge those mistakes that we did in the past, and we develop a revision, and we do a revision for our cases to understand exactly what we did wrong, and we have to follow up, because the key of learning of our mistakes is to develop a revised and significantly more beneficial game plan to implement in the future. What I call that mistake and corrections are Doing mistakes is something very normal, but we shouldn't repeat those mistakes. And I would suggest, mainly for the new generation of graduated dentists, please do not count on Facebook or YouTube to go through your learning. Please, Facebook and YouTube are very nice informative sites, but for learning, please go and attend your courses, attend continuing education courses. We all do mistakes, but we should learn from them and never repeat those mistakes. Thank you all for your kind attention. It had been a pleasure for me to be with you, and I hope that I focused on some of the points taking out from my own practice during the past 20 years to show all the complications or some of the complications that I did during my past. Thank you again for your kind attention, and looking forward to be with you again on other forums. Good day, all.
What's going on, everybody? Hope you have been enjoying the CE courses here for AOS's virtual conference. And as promised, we have had the opportunity to spend some time with some of the amazing companies that are in our profession that are creating innovations, all in an effort to be able to move dentistry forward. And I'm very honored and excited today to be with Greg Pellegrom, who is the founder and CEO of SmileSnap. How you doing, Greg?
Doing great, John. Appreciate you having me on.
Absolutely. Well, thanks for coming on. And I certainly want to get into SmileSnap and the great technology that you've built and talk more in detail of that. But I know before we got started, you and I were just talking about this virtual consultation world just in general, and how through the pandemic and how it's evolving and really changing dentistry. And I know you've lived it and breathed it for the however many years. So love to just kind of get your thoughts first off on, what you're seeing, what it's like, and really the value of, how this is bringing value to the practices and more importantly to their patients.
Yeah, absolutely. Happy to do that. And if I could kind of start off maybe with sort of where the idea began, I think it gives some foundation to the conversation. And that, I spent 15 years in the field as a sales professional on the orthodontic side of the business. And I found that, a lot of my customers our conversations were more about challenges they were facing about patient acquisition. They were seeing a lot of changes in the marketplace and they weren't quite sure what to do. One of the big ones is a lot of their dentists that were referring patients to them, they were either doing it in-house or bringing in an orthodontist. So a lot of those referrals were kind of drying up, except for the really difficult cases, of course.
Right.
And then on top of that, they saw the number of orthodontic residents was growing each year. So the number of graduates. They were seeing the evolution of this, DSO market evolve and more and more offices open in their areas. And then the big one was when the direct-to-consumer aligner companies started to hit the market. They really were unsure as to where to turn to acquire patients. And, I had kind of a unique perspective being a dad with kids in treatment, and I'd get questions from friends and neighbors and family about ortho all the time. And one of the things that came up was it always seems so difficult just to get basic information about treatment. Is my kid ready, or am I ready? What do you recommend? How long is this going to take? And the meat of it really is, what's it going to cost? Right. And what are my options to pay for it? And the only alternative at the time was you have to call our office, schedule to come in for a consult. And oftentimes that might be several weeks out.
Right.
Equipped with little to no information. And we're going to tell you everything once you're in here. And that whole model just didn't make sense with me as a consumer, and especially one that's always embraced, kind of newer technologies that are out there. It just didn't resonate. I don't like going into those situations like that. So, I decided that I was going to try my hand at entrepreneurship and build a platform that allowed consumers to inquire about dental services outside of the office. And that's really where the idea of SmileStap was born. And we launched the platform in April of 2019. My focus initially from a sales and marketing perspective was in ortho. That's where my background and network and knowledge was. And it was a very good product market fit. And the conversations I was having were very positive. Like the doctors would say, hey, this sounds great. Yeah, I could see this evolving and becoming a natural evolution of my practice. Great. Would you like to sign up? And the answer was yes, but not today. I got this going on or that going on. So for about 11 months, I was really, really trying to get this thing going and off the ground. And then you may have heard there was this virus that started to spread around the world pretty quickly. And it was, in March of 2020 that we were truly benefactors of the pandemic and had a platform that when practices closed, it allowed our customers to see existing patients. It allowed them to line up new starts in ortho or cases in treatment in dentistry, so that when their practices reopened, they weren't starting from ground zero. And we experienced significant growth over that time period. So a little bit of background as to where we started, and then what really kind of helped put telehealth, teledentistry on the map. It accelerated that whole evolution that was going to happen regardless. And certainly it helped our company grow.
I love that story. And as you were painting the picture of the family going into the practice to have that consultation, I'm thinking about, after spending time in a lot of ortho practices, the craziness, right, that goes on in there. Just with everything, right? The patients and the team and the busyness of a practice, and how often, families as well as the team, as you know, Greg, they really want to have those conversations and answer all those questions. They don't want to feel rushed. But sometimes the nature, as you know so well, of just what's going on in that practice just drives that energy. And so that was the very first thing that came to my mind, and hearing you kind of paint that picture about the value of this and/or kind of where that came from, which I love. And I think, like you said, when you couple together people becoming more comfortable with technology, people becoming more comfortable on Zoom of all ages, right? Just in general with family and so on and so forth. The timing was great. So how's it been? I mean, how has it been since, the practices have started to use it, the patients have started to use it? What's it been like?
I mean, it's been great. It's really been gratifying to see people embrace this technology and this whole concept. If we think about it, John, and this, it's been this way for forever. The three biggest reasons that people don't go to a dentist is cost, time, and fear. Yeah. And when we talk about cost, it's not what the actual amount is that they can't afford it or make monthly payments. They just have no clue, right? The average person out there has no idea if an implant is $500 or $5,000. Yep. And then when we talk about time, right? It's our most precious asset today, and we're busier than we've ever been. And anything that offers and provides convenience, people are drawn to it. And not only are they drawn to it, they're actually willing to, I know for me, I'll pay extra for it. Right. And when I think back in my own life, some things that I've converted to, for example, I'll never forget the whole concept of getting DVDs delivered to my mailbox with Netflix and no late fees. They had me hooked on that. And here I am still from that day till now, having never stepped foot in a video store since. Granted, It's hard to find one, but still a Netflix customer. When I first heard about Uber, I thought, no way, this can't be true. And then you experience it. And it's that experience as a consumer, that ease of getting a car to take you from A to B and not exchanging money and doing it all through digitally on our smartphones. I haven't been in a taxi cab since, and I travel a lot, and it's been years. So, when we talk about time as being a barrier of entry for dentistry, there are ways that we can lower or reduce that and make it more convenient. And then fear, right? This has always been a barrier for a lot of people out there with the dentist. And the pandemic certainly has not helped that. So by doing things remotely through digital platforms like SmileSnap, we can lower or completely eliminate the cost barrier, the time barrier, and that fear barrier, and get more people inquiring about oral health care and services.
Yeah.
And the underlying part of this, we want all this stuff now, right? We want access to your practice 24/7. We want convenience, we want transparency, and we want it quickly. And we've built this platform so that the practice can deliver on that very, very quickly and efficiently.
Yeah, I love that as well. And I think what I'm excited most when I look at dentistry, it feels like, Greg, that patients, again, another pandemic driven issue, but patients now realize the importance of oral health. Not to say that they didn't before. It just feels like it's been higher up in their minds in regards to all the things that happen in our mouths and how they're connected to the rest of our bodies. That education has come to the forefront with the pandemic, and people be more concerned about their health. And so it also feels like the dental teams, as you know so well, have always wanted to have those conversations with patients. Again, I go back to the craziness of a practice. And so I'm sitting here listening to you talk about SmileSnap and talk about this technology and picturing a patient sitting in the comfort of their own home, being able to connect with their office and having that comfortable environment to ask maybe one or two more questions that they maybe wouldn't ask when they were in the practice. I think that's what's so exciting about that. And I know that you guys have been getting some great feedback. Can you share with everybody, what it's like? Because as you know, you start to implement some of these things, you're going against the grain of what dentistry was like. So I'd love to hear from some of your pioneers, some of your first innovators that use SmileSnap. Like, what has it done for their practices, most importantly?
Yeah, I'm glad to answer that. And you're right. Nobody wants to make buying decisions while they're laid back in a chair and someone's working in their mouth, and they just want to get their teeth cleaned and get out of there because they're probably missing work. And you're trying to sell me something, and it's not a good environment to make those decisions. So it's a great point you make there, John. We've had several hundred success stories with customers of ours, but recently was able to sit down at a conference, because we're back out at the conferences, which feels great, with one of our customers. And he said to me, Greg, he goes, I want to make sure you understand the impact you've had on my business. I said, okay, well, I'm listening, Doc. And he has an ortho practice in the Tampa Bay area. And when the pandemic hit, he immediately implemented SmileSnap. Along with that, because his practice was closed, and he's been practicing 25 years, so he's not new at this, he had to let go of an associate and 8 employees and said, we're going fully remote. And not only did we help him survive when his practice was closed by seeing existing patients and lining up several to start, once they reopened, he told me he had his best year last year in 2020. And this year he's on pace to grow 60% over his best year, which was last year, all without bringing back an associate or these 8 employees.
Right.
But he's one doctor with 3 locations. And he said, look, the reason I can do this, I don't physically have to be in that office on that day, aligning my time with, a potential consult patient. He goes, it renders my availability or our availability for consults, virtually like limitless. And when you really stop and think about it, imagine if Amazon was open 4 days a week from 9 to 5. And in order to buy something, you had to call them, schedule an appointment to go in 2 weeks later. And the item you wanted to buy, you didn't even know what it cost. That's dentistry.
Right.
It's insanity to me from a buying experience. Whereas now through our platform, people can be in the comfort of their own home. They can get to your website and find our software living on your homepage or on a landing page about doing a virtual consult. And whatever service they're interested in, they can give you what they're looking for. They'll take pictures of their teeth. They'll give you their contact information. And that's what they're looking for, a way to engage with you on their time. As soon as they do that, they're done. You essentially have set the hook. Now it's up to you to respond to them in a timely manner. And we've built and designed this so it's literally just a couple of minutes to respond, to move them forward to that next step of saying, yeah, you know what, this sounds pretty good. I didn't realize it is affordable. It's not that invasive. It's not going to be that much of a time commitment for me. I want to move to the next step. And, when we expand that access, when we give meaningful information digitally to patients, they are impressed. This doctor gets me.
Yep.
And it resonates. It makes a big impression. We've got 80 million millennials in this country now, and they're working and they're making money and they're having kids and they're making buying decisions for their household. And guess what? They think differently than my parents did, or even my generation of X.
Right.
And we have to align with their process. They like to comparison shop. They like to have options. They like information initially, to be very easy to access, and they want it online. And the sooner we can really, get behind that model, I think dentistry as a whole can really start to flourish, more so than ever before.
There's no question. And I have a colleague that I work with literally just this week. She mentioned that she had to visit an oral surgeon, and she said, John, she's a millennial. She's like, he actually sat down and he spoke with me and he walked me through it. I felt so comfortable. And I think that's the other thing, as we see with a lot of the millennials, Greg, as you know, is that they want people to take that time. They want people to be able to explain it to them. And so, herein lies the bandwidth issue, right? Is that sometimes that's not always possible in the confines of an office. And so again, just another great placement, I think, for this technology to help a practice go to the market where these patients need this. So I know there's so many exciting things that you guys have. I know you do demos and things like that. I could sit here and talk, a whole another hour with you about this. But I know that you've got a great team and your team can help, everybody kind of walk through this process. Can you let everybody know that's watching where they can learn more about all of you? We're going to put the website link as well as any email that you want right below in the comments so they can get in touch with you guys directly. But as we close up here, could you just let everybody know kind of how's the initial process? Is it a demo? Like, how does that all work?
Yeah, absolutely. So our website is smilesnap.com, all one word, no hyphen, just smilesnap.com. And on there, you can sign up for a demo. I think that is the most powerful way to get an understanding for what we do. There's been some misconceptions about what a virtual consult is. Some people think it's just this live video chat that we're doing, and it couldn't be farther from the truth.
Right.
There's a very sophisticated process, and our SaaS platform guides the patient through it. There's a whole patient management system that we've developed to make it easy for your practice to move these people from an online consumer to a patient, all of these things. So sign up for a demo with one of our account executives, and they'll walk you through about a 30-minute, experience, both as a patient and then as the practice, and can answer all your questions. So that's the best way to learn more about us.
Perfect. And I'm glad that you mentioned the other parts of the platform, right? And that it's not just a video, and there's other aspects of taking that captured video, that consultation, and helping place it in a smart place in the practice so that you can follow up with the patient, right? You can get all the information that's needed, and most importantly, help them and kind of pull them all the way through, which is super exciting. Well, Greg, I'm so excited for you, excited for your success. I think just what's been so fun to watch in dentistry is the entrepreneurism, I guess that's a word, right? That of people that are just taking, problems that you saw, you've been in this profession for a long time. I know you love it. And creating an innovation that's helping dental practices. So I know everybody watching appreciates it. And I want, all of you, if you can, please go take some time to check out what Greg and his team have done, and go do a demo. I mean, I think that there's a lot of patients out there that will really benefit from this and in return help the practice. So Greg, I want to thank you for coming on today and for joining us, and best of luck as you move forward.
Yeah, John, thank you. The opportunity with your platform to get our name, our brand, what we're doing out there, from one entrepreneur to another, much respect. I really appreciate it.
Awesome. Have a great weekend, Greg. Thanks.
Thank you.